Hi, Rafiq. Hi, Satya. Welcome. Okay, so shall we start, guys? Okay. Give me a thumbs up or something to show me that you're ready. All are there. You can see Rafiq, Agaud. Oh, wait, guys. Right now I'm concentrating on multiple gadgets. So, okay. So I think all of us are ready. Hi, Aishwarya. Okay. So you guys are ready. I'm also ready. So welcome, good evening, and welcome to the quick review of FMGE questions. See, whenever this will be a short session. Am I audible properly? Am I audible properly? Okay, Rafiq. Okay. So I'll try to keep it short. As I said, let's try to cover within 2 hours. I hope I'll be able to cover within 2 hours, and I'll be speaking a little quick because my plan is to cover all the chapters in 2 hours. I really don't know whether it will be possible, but let's give it a try. And I hope you guys are there with a pen and paper. And if you want, you can write down. And I'll be talking more and I'll be writing less because we want to spare time, right? Okay, so we'll start with, see, chapter 1 is not that important. We'll start with chapter 2, and there are 25 chapters in Park textbook. But let me tell you, there are only 2 chapters which are really big. That is chapter 3, which is general epidemiology, and then communicable disease, non-communicable disease, and national programs. They are also, when club, will become a big chapter. Okay, so actually, whenever I start any quick review program, last year I did one for FMGE. Then students were like, "Madam, you're starting with the boring topic." Then I changed the topic. In next NEET, I started another topic. Then they were like, "Again, you're starting with the boring topic." In INICT also, I changed the topic, and again, students are saying the same thing. When I retrospectively thought, then I realized that every topic in community medicine is, according to you, is boring. So this time I thought, anyway, we'll go chapter wise. So there will not be any complaints from students. Okay. Moreover, we'll be, without missing any topic, we can cover everything. So I want your complete attention for the next 2 hours. And I'm not telling you it's going to be easy, but let me promise you this is going to be worth it. Okay, so shall we start? We start with the chapter 2. Chapter 1 is not that important. It has some few pictures which are important, but not that much. So let's start with chapter 2. After that, after finishing all the topics, we'll come to chapter 1, if time permits. So from chapter 2, the most important topic is levels of prevention. Okay, now let's see which are the levels of prevention. So first, we are going to talk about levels of prevention. Before talking about levels of prevention, first you should know what is natural history of a disease. What is natural history of a disease? As the name indicates, it is the process by which a disease evolves over time from its first stage till the end in the absence of any external intervention. That means if you don't do anything from outside, how a disease progresses from its first stage till the last stage. And the usual natural history is something like this, right? You have a very healthy community free of any risk factors. What is the first thing that is happening? Some risk factors are emerging, right? Then man is in the midst of risk factors. But it will take some time for the disease to develop. After some time, naturally, the disease develops. Then it will go on for complication and finally some outcome. Depending upon the disease, sometimes it will be death, sometimes it will be natural cure. It depends on the disease, right? This is a natural history. Now, depending upon the point where you actually intervene from outside, we have how many levels of prevention? The first question, 4 levels of prevention. Which are they? primordial, primary, secondary, tertiary. Okay, now let's see what is primordial. Primordial means you are intervening at the very first stage, where you are trying to prevent the emergence of risk factors in a community where it has not yet evolved. Okay, so this is primordial. You are trying to prevent the emergence of risk factors. Suppose you failed here, what will happen? Risk factors will come up, right? And then man is surrounded by a lot of risk factors, but no disease yet. What do you call that phase as? That is a next MCQ. It is known as pre-pathogenesis phase. That means pathogenesis has not started. If you intervene at this position, then you call it as primary. This is known as primary. So what is primary? You are trying to prevent the emergence of disease in a community with risk factors. Okay, that means both primary and primordial you are doing before the disease emerge. Whereas, I'm so sorry, something came up here. Just leave it, okay? Or else I'll just okay. So that is primary. Now, after the disease develops, that means in the pathogenesis phase, you have two more left. Which are they? Secondary and tertiary. That means both secondary and tertiary you are applying in the pathogenesis phase. Now my question is, what is the difference? What is the difference? You know, the pathogenesis phase is again divided into two. Early pathogenesis phase and late pathogenesis phase. Okay, early means the disease has just started. Early means the disease has just started. That means the man is still in the, or the patient is still in the reversible phase. If you can intervene at this point, you can bring the person back to a normal life. Are you understanding? Okay. Whereas in late pathogenesis phase, as the name indicates, it's already late. That means the patient has already gone to the irreversible phase. Now, whatever you do, however you try, you will not be able to give a normal life to that patient. What you can do to the maximum is you can, you can rehabilitate and you can prevent further disability. Okay. So if you are intervening in the early pathogenesis phase, it is known as secondary prevention, where you're trying to prevent complications. Whereas if you are intervening in the late pathogenesis phase, it is known as tertiary prevention. I hope you're with me. So these are the 4 levels of prevention. Okay. So each of this is an MCQ. Now moving on to the next. Now let's see which are the modes of intervention. Very, very important. This is a very important MCQ. Modes of intervention. That means what are the things that you can do under each, or what are the activities that you can undertake under each of these levels of prevention. Okay, under primordial. See, primordial means you're trying to prevent the emergence of risk factors. So you have to go to a community where there are no risk factors. That means you may have to go to schools, right? And you have to teach children, their parents, their teachers, so that these children will never ever adopt any unhealthy behavior. So health education is what you're giving in primordial. Now, primary, 2 modes of prevention, which are the health promotion and specific protection. Health promotion and specific protection. Now, what is health promotion? As the name indicates, you are simply improving the health, or you are promoting the health by asking them to take good food, good water, then asking them to do regular exercise. So you are trying to promote their health so that they can fight against as many diseases as possible. Whereas specific protection is, as the name indicates, you are specifically trying to prevent one disease alone. For example, vaccination. Okay, then vitamin A prophylaxis, all these are coming under specific protection. So under primary, you have to health promotion and specific. Now, what is secondary? Secondary, I told you, you are trying to detect the disease at the earliest and do some treatment, right? So you are doing it in the early pathogenesis phase. So what all interventions you have? Early diagnosis, screening, and treatment. So guys, very, very important MCQs. Screening is coming under secondary. So you can remember this S and S. Screening is coming under secondary. Put it in your brain. Okay, screening is coming under secondary. And tertiary that we have already discussed. In the late pathogenesis phase, what you can do to the maximum is disability limitation and rehabilitation. Each of this is an MCQ which you can definitely expect. Okay, each of this is an MCQ. So we are done with levels of prevention, modes of intervention. 2 topics covered. Now coming to the next subtopic from chapter 2. PQLI and HDI. First MCQ, what is PQLI? Physical Quality of Life Index. HDI, Human Developmental Index. Okay. Now, which are the indicators coming under PQLI? See, PQLI or Physical Quality of Life Index, there are 3 indicators under PQLI and HTI. So you can remember like, see, ill and kill. Sorry. Ill and kill. Okay. So LI is starting with ILL. Ill and kill. Now what is ILL? Infant mortality rate, literacy rate, life expectancy at 1 year. Whereas HDI is kill, right? So what is K? Knowledge. I is income, not IMR. See, what do you mean by development? You know, human developmental means development is PASA, right? Money is very important. So there it's not IMR, but income. And life expectancy at birth. So just remember ill and kill, you will never ever go wrong. PQLI. So LI, you're starting with ILL. That is a code. Okay. Even then, you can have a doubt. That, what is that? Life expectancy at 1 year. Is it coming under PQLI or HTI? Just listen, guys. What is I in PQLI? It is infant mortality rate. Now, what do you mean by infancy? 0 to 1 year, right? So the 0 to 1 year is already covered under IMR. So there you start counting from life expectancy from 1 year onwards. Whereas in HDI, I is income, right? So there you start counting from birth onwards. Is that clear? Okay. Next MCQ is a range. Again, very easy. If you consider PQLI and HDI, which one has got more letters? PQLI, right? 4 letters, here 3 letters. So the one which has got more letters has more range, 0 to 100. Whereas the one which has got less letter, less range, 0 to 1. This is 0 to 100 and this is 0 to 1. Is that clear? Each of this is an MCQ. I'm only going through those MCQs which have already come for your previous exams. Okay. I hope FMGE candidates are watching this. And few NEET candidates also would be there. But, you know, because nowadays, whether it is FMGE or NEET or INI-CT, exams are, I mean, all the questions are kind of tough only. You can't say that it will be very easy for FMGE candidates, whereas it will be very tough for INI-CT. More or less, all the questions are kind of somewhat same. Okay, so I think all the questions, it's very important to discuss. And what I am mainly discussing is FMGE questions. Okay. Now, coming to multidimensional poverty index. This was a previous FMGE question, multidimensional poverty index. So as the name indicates, you are trying to find out the poverty in various countries. It ranges from 0 to 1. 1 means highest deprivation level and 0 means lowest deprivation level. Now, the question which came for your exam was, which are the indicators? So here also we can remember the same KIL, K-I-L. K is knowledge or education. I is income. Income can be taken as a proxy of decent standard of living, right? So living standards. And longevity is health. Okay. Now, let's see which are the indicators. This was the previous year question. Under KIL, you have 2 indicators. These are the dimensions, and under KIL, you have 2 indicators. That means knowledge you measure as years of schooling and children enrolled. Now, coming to living standards, guys, there are actually 6 indicators which you can remember like tires. Water and electricity, you can remember. If no water, no electricity, right? Then cooking fuel and toilet. If there is no cooking fuel, then there is no need of toilet, right? Okay. Then floor and assets. If there are no floors, you won't be able to keep any assets. Okay. So these are the 6 indicators coming under living standards or income. And under longevity, you have child mortality and nutrition. These are previous MCQs. Okay. And then comes last year MCQ, Global Hunger Index. It is to measure hunger globally, mainly for developing countries. Now the question was, this also ranges from 0 to 100. The question was this: which are the indicators that are coming under Global Hunger Index? Now, please listen. You're trying to find out the hunger, right? So there are 4 indicators. First one, percentage of undernourished population. What percentage are undernourished population? Then you have 3 more, and all these 3 have got under 5 indicators. One is under 5 death, then Under 5, wasting. Wasting means, children who are very thin. Then under 5, stunting, who are dwarfs. Okay, so under 5, deaths, under 5, wasting, and under 5, stunting. This way you can remember. Is it clear? Hope you are understanding. Are you there? Gautam, Dana, Rafiq? Okay. So, these are very important. Now, moving on to, I'm going to show you something. This is how you grade the hunger index. Now, you can go through this later. India is coming under serious hunger, which ranges from 20 to 40. India is coming under serious hunger. And the latest value of India or score is 27.5. And you know what is our position? Out of 116 countries that participated, India's hunger is in the range of 101. Our rank is 101 out of 116. That means very much hungry country, right? Okay, so we are coming under serious hunger. So these points you have to keep in mind. And the latest score is 27.5. So this was a question which came last year, Global Hunger Index. Now coming to the next question, which was a question 2 years back, hidden hunger. What is hidden hunger? That means hunger is there, but when you look at the child, you won't be able to find it. It's hidden. This is micronutrient deficiency. This is for micronutrient deficiency. What are the micronutrients? Vitamins and minerals. Okay, so this is hidden. You can remember, hidden means you won't see because it is micronutrient deficiency. Now coming to the last part from chapter 2, ICD 11. Now we have ICD 11, right? You guys know about ICD 10. Now we have ICD 11. The MCQs that you have to remember from ICD 11 are 3 volumes like you have in ICD 10. How many chapters? Here you have 26 chapters. Earlier it was 21 with V and X. V is supplementary section and X is extension code. This is an MCQ. How many chapters are there in ICD 11? Now moving on to the last part, ICD coding of COVID-19. See, COVID-19 is very, very important. So you should also be knowing what is the coding of COVID-19. Okay. Anyone? Let me just check because in my group, I had actually, I made a slide and I circulated the ICD coding of COVID-19. Does anyone know? Anyone? Vicky? Anyone? Dana? Gautam? Okay, I'll give you a clue, okay? Someone who is everybody's favorite. Who's this? At least that you can tell me. 107. Who's this? Yeah, Daniel Craig, James Bond, right? So James Bond is very powerful. COVID-19 is also very powerful. So you can remember that number 007 of James Bond. So ICD coding is not exactly 007. Can you see? 0 ka upar ka chala gaya. So it is open. U07. It's not 007. U. The upper part is removed. So U07.1 is COVID-19 if the virus is identified by RT-PCR or something. And U07.2 if the virus is not identified. That means you are suspecting or a probable case of COVID-19. So please remember this. So you can always remember COVID-19 coding to James Bond. Okay, never forget. Moving on to a big chapter, that is chapter 3. 0.07. U07. Okay, good. Now moving on to the biggest chapter in our Park textbook, which is epidemiology. So let's see. Yeah, good vision. Very good. 007. Okay, fine. So mortality measures. Now, in epidemiology, the first important subtopic is measurement of mortality, morbidity, and disability. That means how many people died, how many people are morbid, and how many people are disabled. Okay, so let's see which are the mortality measures. Very, very important. So first of all, let me tell you, see, there are some formulas which you should know. You should know the names of these mortality measures. You should know the formula, and you should be able to substitute some values for solving some problem-based exercises from mortality measure. And it's very, very simple. Just listen, it's very simple. We'll start with the first one, crude death rate. As the name indicates, what do you mean by crude? Crude means, non-specific. It will only tell you out of 1,000 people living in an area, how many died. So naturally, what is going to be the formula? Total number of deaths divided by median population into 1,000. So that will tell you per 1,000 people living in that area, how many died. Now, why do you say it is crude? Because it will not give you any specific information like which disease is killing the people. Is it some communicable disease or non-communicable disease? Or it will not give you any specific information like which part is dying. Is it killing children or adults or elderly? Don't you think such information are very important? Yes. So we have the next one, which is specific death rate. As the name indicates, this will specifically tell you which disease is killing the people or which part is dying. So what is going to be the formula? Number of deaths from specific disease or occurring in a specific age group or sex group divided by median population into 1,000. So that is specific death rate. The third one is proportional mortality rate. Now, what is it? Nothing to mug up. As the name indicates, what do you mean proportion? Proportion means a small portion out of the whole. Mortality means death. So what is proportional mortality rate? Out of total deaths due to all causes, what percentage died because of one disease alone? So naturally, what will be the formula? Number of deaths because of one disease divided by deaths due to all causes into 100. So that will tell you what percentage out of total deaths are because of COVID or hypertension or diabetes, like that. Okay, so that is proportional mortality rate. And the last and the most important is case fatality rate. Now, what do you mean by case fatality rate? The number of deaths due to one single case. Case means disease. Number of deaths due to one single disease. So how do you find that? Out of total people who got one disease, how many died? So what will be the formula? Formula will be total number of deaths due to one disease divided by total number of cases who got that disease. That means out of total number of people who got a disease, how many died? Okay, so that is case fatality rate. Okay, now two very important MCQs from case fatality rate. A very frequently asked MCQ. This shows the killing power of disease. Do you agree with me? This shows the killing power of disease. Second MCQ. This is related to the virulence of the disease-causing organism, right? I hope you will agree with me. Okay. See, if I say that the case fatality rate of Nipah disease is 80%, what do you mean by that? 80% of people who got the disease died. So that will show the killing power of the disease as well as it is related to the virulence of the disease-causing organism. Okay. Okay, you're asking PDF. First, listen. Shalakha. Let's think about PDF. First, listen to the class, dear. Okay, related to the virulence. Now coming to morbidity. So we are done with mortality. Mortality may we had crude death rate, specific death rate, then proportional mortality rate and case fatality rate. Next is morbidity. By the way, what do you mean by morbidity? See, everyone who's getting disease are not dying, right? Some people are morbid. That means any deviation from normal health you call as morbidity. Now, how do you measure morbidity? Using two parameters. That is the next MCQ. Morbidity is measured using two parameters. Mortality, we had 4. Here we have 2. Which are they? Anybody? This you should be knowing. Please, please answer. Please. Write something. Come on, guys. Very good, Vikram. Very good. Very good. Excellent. Ronak, Dali, yet to come, man. Okay. It is prevalence and incidence. Okay, prevalence and incidence. Very, very, very good. Very good. Aishwarya, good. Vicky, good. Okay, prevalence and incidence. So, morbidity is measured using two, prevalence and incidence. Never forget. Now, the formula of prevalence. You can remember, prevalence means at one point of time, how many people are having a disease. Okay, so all cases, for example, what is the prevalence of COVID? So you go to an area, do a survey and see how many people are having COVID at that point in time. Okay. Okay, so that is prevalence. All cases divided by total population. That means out of total population that you have survived, how many are having that particular disease. Okay, so you can remember all and all. I'm just trying to give you some last minute tips so that it will be easy for you to remember all and all. Whereas incidence means you are only calculating the new cases. So you're starting with a population without that disease and you're following them in the future to see how many new cases will develop. Okay, so it is new cases divided by, it's not total population, but total population at risk. Okay, total population at risk. So I want to ask you one question. What do you mean by total population at risk? That means each and every person in that population is likely to develop that disease, or each and every person in the numerator should be susceptible to develop that disease. For example, see, numerator, there is no doubt, right? There are two N's in incidence. So you can remember new cases, N and N, all and all. So here it is all cases. Here you have only new cases. Now my question was, what do you mean by total population at risk? That means, for example, suppose I want to calculate the incidence of, say, chickenpox. Okay, that means number of new cases of chickenpox that can happen. Can I include those children who already had chickenpox in the denominator? No, because they are not at risk. Can I include those children who have received chickenpox vaccination in the denominator? No, because they are not at risk. Hope the message is clear. Is it clear? So in the denominator, you should be including only those who are at risk for developing the disease. So the formula of prevalence and incidence both are important. And when it comes to incidence, the denominator itself is an MCQ. Is it clear? The denominator itself is an MCQ in incidence. Okay. And the next MCQ is P equal to, yes, susceptible to the disease. Very good, very good. Susceptible to the disease. P equal to IUDD. By the way, what do you mean by P? P is prevalence. I is, incident. What about D? What is D? D is duration. Very good, duration, right? The more time is given, more new cases will develop, and that will naturally add on to the prevalence, right? So prevalence is directly proportional to incidence as well as duration. Now I'm going to show you a picture which has got 4 MCQs. Keep this in your mind. Just have a look at this and it's very simple. As incidence increases, prevalence increases, right? As recurrence increases, again, prevalence increases, right? As cure rate increases, what happens? Prevalence decreases. As mortality increases, again, prevalence decreases, right? So these are 4 important MCQs that you have to keep in your mind. Okay. Now moving on to disability. Now let's see which are the disability. Disability means inability to do a routine function. Yes, Atmika. Yes, Atmika, you are exactly correct. You get prevalence from cross-sectional study. This is what Atmika has said, and it is correct. You get prevalence from cross-sectional study, whereas you get incidence from cohort study. Very good, dear. You're correct. Now, let's see which are the disability measures. There are 4 disability measures. So, we talked about 4 important: mortality, 2 morbidity. Now, again, coming to 4 disability measures. One is DALY, Halley, Qualley, and Sullivan's Index. So, these 4 names, keep in your mind. Next MCQ. DALY is disability adjusted life years. This will give you the burden of disease. That is another MCQ. Burden of disease is given by DALY. Okay. Next MCQ. Sullivan's Index. This is life free of disability. Life free of disability is Sullivan's Index, which is recently replaced by, this is given in your Park textbook, DFLE, Disability Free Life Expectancy. Now, Sullivan's Index is replaced by a new name, DFLE. That means Disability free life expectancy. Is it clear? So these are the MCQs from disability indicators. Now moving on to the next one. We have two terms, isolation and quarantine. Nowadays, even the common man is saying a lot about isolation and quarantine. Are they same or different? Definitely, they are different. Now, let's see what is the difference. That is the MCQ. Even the doctors confuse between isolation and quarantine. After becoming positive, many doctors are coming back and saying that I was in quarantine. But that is not quarantine. That is isolation. Why? See, isolation. To whom do you advise isolation? For a diseased person, right? And for a diseased person, you are physically separating him. It is for a diseased person, a positive person. You are physically isolating him. What is your purpose? So that, what is the purpose of doing that? This person will not give disease to another person, right? So my question is, how long you should keep them under isolation? For the longest period of, or till they can give disease to another person. What do you call that as? Till the longest period of infectivity. Infectivity. So you are physically separating a positive person for the longest period of infectivity. That is isolation. Whereas quarantine is for a person who is exposed. It is for an exposed person. Okay, you suspect that he might be having virus inside his body. So you are restricting their freedom of movement. You're not physically isolating them, or you're not physically separating them. You're restricting their freedom of movement. Why? Because you suspect that they might be having virus inside the body and you want to confirm it, right? So how long you have to wait? That is a question. You want to confirm whether this person has virus inside the body or not. So how long you need to wait? Yes, susceptibles are kept under quarantine. For how long? Very good, Ronak. For the maximum incubation period. You're saying 14 days because you have only COVID in your mind, Dana. I'm simply asking about, in general for the disease. Okay, 14 days, you're right. Okay, so this is for the longest incubation period. So quarantine is done for longest incubation period. That means even after waiting for the longest incubation period, if the patient is not developing a disease, that means he or she doesn't have virus inside the body. Then you can ask them to go and mingle with the public. Okay, so isolation is for a positive person for the longest period of communicability, whereas quarantine is for an exposed person for the longest incubation period. Each and every point is an MCQ. Now, moving on to the last part in chapter 3, which is study design. Okay, so we are going to talk about study designs. Very, very, very important topic. Very important topic. Okay. Now, all these study designs that you see above are important for your exam. Okay, so cross-sectional is a descriptive study design. Now, let's talk about the MCQs. Cross-sectional is a descriptive study design where you are simply describing how many are having disease, how many are males, how many are females, what are the complications, like that. Case control and cohort are analytical study designs. They are analytical study designs. That is a second MCQ. RCT or randomized control trial is an experimental study design. These are the MCQs. Okay. Now, meta-analysis is something different that we will be discussing after some time. So let's start with the first one, case control and cohort. As I told you, both are analytical study design. Now comes the next question. What do you mean by analytical study design? Analytical means in both case control and cohort, you have an exposure and an outcome. You have an exposure, like say smoking and lung cancer. Okay, so in analytical study design, both case control and cohort, you always have an exposure and the outcome. And you want to know whether this exposure and outcome are related or not, whether they are related or not. That means whether they are positively related or negatively related. Okay. And if so, how much is the strength of association between this exposure and outcome? Okay, this is what you're trying to find out in analytical study design, both case control and cohort. Now there comes the next question. Then what is the difference between case control and cohort? The difference is that in case control, as the name indicates, you're starting with the cases and controls and you're retrospectively, you're starting with the outcome and you're retrospectively assessing the exposure. That is case control. Whereas in cohort, you're starting with the exposed and you are prospectively following them to see how many will develop the outcome in future. So the only difference is the direction in which you do the study. In case control, you're starting with cases and controls and you're going backward, whereas in cohort, you're starting with the exposure and you are going forward. Is it clear? Okay, now let's see case control. As the name indicates, cases and controls. For example, like I said, if I want to know the relationship between smoking and lung cancer, what I'll do is you take cases and controls. That is why it is known as case control. You start with cases and controls. You take a group of lung cancer patients, then another group without CLR. Okay. Then you ask each and every patient in the case about their smoking history. You go and ask them, do you smoke or have you ever smoked? And you find out, and same question you have to ask among the controls as well. And then you see the percentage of smokers among your cases and percentage of smokers among your controls. And this difference in the percentage of exposure is what you are comparing in a case control study. Okay. Whereas in a cohort, case control is known as case control because you're starting with cases and controls, right? Diseased and non-diseased. Cohort is known as cohort because you are starting with cohort. By the way, what do you mean by a cohort? What you see here is a cohort. A group of army men marching for the battle is a cohort. So they look very similar, right? And for our study design, cohort is a group with similar exposure. So what you do here is you take a group of smokers, then you take a group of non-smokers, then you prospectively follow them into future to see what percentage of your smokers will develop disease at the end of say 5 years or 10 years and what percentage of your non-smokers will develop CLM at the end of 10 years. And this difference in the percentage of outcome is what you're comparing in a cohort study. Are you with me? Okay, so this is an image-based question. Okay, this is an image-based question. This is for cohort and what I had shown earlier is for case control. Now let's see the second part. After this, how do you analyze? You want to find out the strength of association. So strength of association in a case control is given by, how do you find out strength of association in a case control? Very good, very good, very good, Dana. It is odds ratio. By the way, what is odds ratio? What is odds? What is the odds of getting head when you toss a coin? What is the odds of getting 6 when you're tossing a die? Odds means it is probability. So in odds ratio, you're trying to find out what is the probability of outcome among the exposed and non-exposed, or what is the probability of exposure among the cases and control. Okay, that is what you are trying to find out in odds ratio. Now, I'm not going into the details. See, here I have 100 CA lung patients. I have 100 controls. And when I ask them about the history, checking the live chats. AC by BD. No. Dr. Vin? Yeah, Vikram, you're right. AD by BC. Okay, now I'll tell you how to do it. So I have 100 cases, 100 controls. When I asked them about the smoking history, I found that 60 of my lung cancer patients were smokers and 80 of my normal people were non-smokers. Okay, so I got 40 here, 20 here. So this is my A, this is my B, this is my C, this is my D. Now I want to find out odds ratio. Odds ratio, like you said, odds ratio is also known as, that is next MCQ, cross product ratio. It is also known as cross product ratio. Why? Because when you put a cross, the result that you get AD by BC is odds ratio. Are you with me? Now coming to the next MCQ. How do you interpret? If odds ratio is more than 1, that means it is a risk factor. Before that, let me tell you, see, tell me what is the odds ratio here. Here you will get odds ratio as 6. Here you will get odds ratio as 6. Now what do you mean by odds ratio of 6? That means smokers have 6 times more chance for developing lung cancer than the non-smokers. So the point that I want to tell you is the MCQ that you have to keep in your mind is, if odds ratio is more than 1, that means this exposure is a risk factor. If odds ratio is less than 1, that means this exposure is a protective factor. And if odds ratio is equal to 1, that means there is no association between this exposure and outcome. Okay, whether you are exposed or non-exposed, the outcome is going to be the same. That means there is no relation. Okay, So that is about odds ratio, which will give you the strength of association in a case control. Now let's see which are the outcome measures in a cohort. In cohort, unlike in case control, there are 4 outcome measures. First, let me give you the names. It's very simple. One is incidence, relative risk, attributable risk, and population attributable risk. Now comes the next very important question. Which among these 4 will give you strength of association? Okay, I'm waiting for your answer. Which among these 4 will give you strength of association? Okay, chatting started. Relative risk, attributable risk, relative risk. Okay, majority is correct. Majority is correct. Only 1% said attributable risk. Very good, very good, very good. All except 1 is correct. It is relative risk. So relative risk will give you strength of association in a cohort study. So please keep that in your mind. Relative risk. This is a very, very commonly asked MCQ. Very important MCQ. Relative risk will give you strength of association in a cohort study. Whereas in a case control study, odds ratio will give you the strength of association. Okay. Now let's see what is incidence. I think I don't have to tell you what is incidence. See, in this particular example, I have 100. It's a cohort study. So I have to start with smokers and non-smokers, right? So I have 100 smokers. I have 100 non-smokers. 1 second. I hope you know how to construct a 2 into 2 table. Don't you know that? Oh my God, I'm losing time. Don't you know how to construct a 2 into 2 table? You know that, right? See, where do you write disease and where do you write the exposure? Always remember this CD. Okay, CD. In column, always write disease. By the way, guys, this is column. Okay, this is column. And in column, you always write disease. And here, along the row, you write the exposure. Okay, so just remember this CD, just in case you don't know how to construct a 2 into 2 table. So I have 100 smokers. I have 100 non-smokers. I followed them for 10 years and I found that out of 100 smokers, 10 developed CA lung at the end of 10 years and 2 of the non-smokers developed CA lung at the end of 10 years. So this is how you construct the 2 into 2 table. I hope you're with me. Okay. Now what is incidence? Incidence of disease among the exposed. Exposure is smoking, right? How many smokers? 10 out of 100. Next is incidence of disease among the non-exposed or non-smokers. It is 2 by 100. By the way, what is incidence? New cases among the exposed. Okay. Those who are susceptible to develop the disease. Okay. So this is incidence. So there is nothing more about incidence. Now, what is relative risk? Very, very important. Relative risk is, how do you find out relative risk? See, guys, once you get incidence, no, all the other 4 are application of this incidence. So there is nothing more to learn. What is relative risk? Once you have got incidence, then incidence among the exposed divided by incidence among the non-exposed is the relative risk. Next MCQ, it is also known as risk ratio. This is also known as a risk ratio. Oh, something went wrong. Sorry. Current. Are you seeing this? Yeah. This is the problem when you go for a live session. You have to depend on a lot of things. Many things can go wrong, right? Okay, so relative risk, as we said, it is also known as risk ratio. That is one MCQ. Then the formula, incidence among exposed divided by incidence among non-exposed. In that particular question, how much will you get? 10 divided by 100, the whole divided by 2 by 100. So you will get relative risk as 5. Now, what do you mean by relative risk? 5. That means smokers have 5 times more chance for developing the disease than non-smokers, right? So what I want to tell you is, both will give you strength of association. So the interpretation will also be the same. If relative risk is more than 1, that means this exposure is a risk factor. Less than 1, that means this is a protective factor. Equal to 1, that means there is no relation. Hope you're with me. Okay. So that is relative risk. Now attributable risk. Now what do you mean by attributable risk? See, attributable risk means, you know, almost every disease has got a multifactorial causation, right? So you want to know what is the out of total risk, because of all the risk factors, what percentage is attributed by one single risk factor alone. See, these are the known risk factors in lung cancer. I want to know the attributable risk between smoking and lung cancer. That means I want to know what is the percentage risk attributed by smoking alone. Now, what is the formula? Formula is, again, it depends on the incidence only. Incidence among exposed minus incidence among the non-exposed divided by incidence among the exposed. Okay. I'm not going into the details. For details, you can refer my class. Anyway, here you will get it as, say, 80%, right? If we go to that old example, you will get it as 80%. Now, what do you mean by attributable risk of 80%? I said, what is the risk attributed by one single risk factor alone out of total risk because of all the other risk factors? So how do you interpret this? This means that if you're getting attributable risk as 80%, that means 80% of lung cancer cases that you see among smokers is only because of smoking. So if you can successfully remove this habit of smoking from among smokers, you can prevent 80% of lung cancer cases which are likely to happen in smokers. Okay. And the rest 20% is because of the other risk factors. Are you with me? Similarly, in population attributable risk, I'm not going into the details, where you had exposed in the formula of attributable risk, that is replaced by population. So in the other one, it was incidence among the exposed. Here it is incidence among the population minus incidence among the non-exposed divided by incidence among the population into 100. Now, I'm not going into the details. Suppose you are getting population attributable risk as 50%, just like that, I'm telling you. Okay, if you're getting population attributable risk as 50%, that means 50% of lung cancer, which is happening in a population which includes both smokers and non-smokers, is because of smoking. So if you can make that community a smoking-free community, you can prevent 50% of lung cancer cases which are likely to happen in that. So the point that I want to tell you is, both attributable risk and population attributable risk are for prevention. That will help you. The public health importance is for prevention. Is it clear? So that is the next MCQ. Attributable risk and population attributable risk are for prevention. Will every chapter be covered today? I hope so, man. I don't know whether I'll be able to do that. That is my hope. Okay. Now coming to cross-sectional study. So I'm not going into the details of cross-sectional study. Cross-section means one-time examination. Example is survey. Okay, doing a survey. You're going to a population, you are doing a survey, and you're seeing what percentage of people are having COVID at that point. Okay, so what you get is prevalence. So the outcome that you get in a cross-section is prevalence. That is the next MCQ. So survey is an example, and what you get out of cross-section is a prevalence. Okay. It is neither forward-looking, neither backward-looking. Okay, it's neither forward nor backward-looking. Okay, that means this is only looking at one point where you're taking the survey, right? By the way, which is forward-looking? Forward is cohort, whereas backward-looking is case control. Okay. Now coming to RCT, randomized control trial. These are very simple. See, randomized control trial is an experimental design, right? Here what you do is, you take a group of patients. Just listen. Okay, you take a group of patients with one particular disease, you divide them. You divide or you randomize them into two different arms of almost equal size. One is known as treatment group and the other is known as control group. To treatment group, you give your drug, and to the control group, you give placebo. Then you follow up for them for, say, some 10 days or 20 days to see what percentage of those who receive the treatment got cured and what percentage of those who receive placebo got cured. And this difference in the outcome is what you are comparing in an RCT. Okay. Now, coming to the next MCQ. Randomization is known as heart of RCT. A very, very important question. Randomization is known as heart of RCT. Why? Because the randomization will remove two very important bias, which are selection bias and confounder bias. Don't ask me what is selection bias and confounder bias. It's there in the class. Due to lack of time, I'm not going into those details. It will remove selection bias and confounder bias, and it also makes the groups comparable. That is why it is known as heart of RCT. Now moving on to blinding. Next MCQ, blinding. So blinding is something. Case control, cohort. Okay, good. Crossover, RCT, Avinash, if I get time, I will definitely tell you. But, I can't cover everything. Even while taking the class, I'm thinking whether to include that or this. Okay. Because it's a huge topic, right? Okay, blinding. Now, what is blinding? Blinding means blindfolding, right? Or masking. Now, what is the purpose of blindfolding? You cannot see, right? You cannot see what? You cannot see what belong to the treatment arm and who all belong to the control arm. If you know who all belong to the treatment arm and who all belong to the control arm, bias can occur at 3 different points. Which are they? One is subject bias. If the patient knows whether he is getting treatment or placebo, this can happen. Second is investigator bias. If the doctor knows or the nurse who is collecting the data knows who all are getting which all drug, this can happen. And the third is analyzer bias. If the analyzer or the statistician who is dealing with the whole data knows about the patient allocation, this can happen. Okay. So to remove this, we have 3 different bias, 3 different types of blinding. Which are they? I hope you know about what is subject bias. And see, suppose I know that suppose there is an RCT for a painkiller, and I know that I'm getting placebo. If the doctor is coming and asking me, how is your pain? Are you relieved of your pain? Even though I feel a little relieved of pain, since I know at the back of my mind that I'm getting a placebo, I may have a tendency to give a negative answer. I may say, no, doctor, I still have that pain. This is known as subject bias. Same can happen if the investigator knows and if the analyzer also knows. Okay, I'm not going into those details. Anyway, to remove this bias, you do blinding. We have 3 types of blinding. Which are they? We have single blinding, where subject alone is, that means subject doesn't know whether he is getting treatment or placebo. Then you have double blinding, where both the subject and investigator doesn't know who all are getting which all drugs. Then you have triple blinding, where all 3 doesn't know who all are getting which all drugs. Now comes the next MCQ, which is the most commonly used one. Most common is double blind. The best is triple blind is the best. Okay, all these are MCQs. Good. Okay, Dana. Can you tell quarantine of some important diseases? We are coming to diseases, Shika. Wait, okay. Now, coming to the outcome measure in an RCT. In RCT, what actually happens is you are giving drug to the patients, right? And you're asking them to come for a follow-up. This is what we are doing. And in field, what happens is a few patients will never ever come back for the follow-up. They just run out of your study. So the problem is whether to include them or exclude them at the end of your analysis. And in RCT, what you do is intention to treat analysis. That is the next MCQ. Whenever you hear this term, intention to treat analysis, please do understand it is with regard to RCT, and in intention to treat analysis, the dropouts are included in the analysis. That is the next MCQ. Okay. So the outcome measure in an RCT is intention to treat analysis, where dropouts are included in the analysis. This is an MCQ. This is also an MCQ. Okay. Now coming to the last, which is meta-analysis. Now, what is meta-analysis? As the name indicates, meta means, think about metamorphosis. Meta means again and again, you are analyzing the result from previous studies. Okay. For example, suppose I want to do a meta-analysis to know the clinical features of COVID-19 in India. Okay, I want to do a meta-analysis on clinical features of COVID-19 in India. I know I am not the first person who is going to do this. Many people have already done a lot of research regarding clinical features of COVID. So what I do here is I simply sit at home. Then through internet and through journals, I will collect all those studies which were done previously by other researchers about the clinical features of COVID. I'll compile their results and I'll come up with the new result. This is meta-analysis. So in meta-analysis, you are not directly collecting data from the patients. Instead, you are combining the results of previous research to arrive at a conclusion. Are you with me? So this is meta-analysis, and this is the diagrammatic representation of meta-analysis. Hope you're with me. This is the diagrammatic representation of meta-analysis. So this is also an MCQ, an image-based question of meta-analysis. Now coming to how to interpret the results of meta-analysis. See, I'm not going to tell you what this is, but just the name. Please do understand that the result of meta-analysis is analyzed in the form of a graph known as, what is this? This is forest plot. Nothing more, nothing less. So if you see a diagram like this, please do understand this is forest plot. And forest plot, using forest plot, you analyze the results of a meta-analysis. So this is the meta-analysis where you're comparing odds ratio of 5 different studies. Just understand that much. Okay. So we are done with that biggest chapter. What is the time now? Okay. A big chapter, which is epidemiology, and which was very important for your exam. Now let's see how long we'll be able to move forward. Coming to chapter 4, which is screening for diseases. Are you guys, I'm extend the session if possible. Yeah. I will try. Okay. So screening for diseases, very, very important. Moving on to the 4th chapter. Okay. See, you do screening to find out certain diseases, right? So in screening, from all the questions regarding screening, first of all, let me tell you, see, in this particular chapter, you are trying to find out how good is a screening test in detecting the disease. Okay. So you are comparing the goodness of a screening test using certain parameters known as sensitivity, specificity, positive predictive value, and negative predictive value. Now let's see how to find them. Please listen. Just listen. Same 2 to 2 table. Here, I'm going to find out how good is Mando test. By the way, Mando is for TB, right? How good is Mando test in detecting TB? So I have 100 TB patients with me. Same CD here as well. Okay, same CD applies everywhere. Disease always go to the column. Disease always go to the column. Okay, so I have 100 TB patients who are diagnosed to be having TB by some gold standard test, NAT, CB NAT or something. And I have 100 normal people without TB. And I applied Mando test. And I found that out of this 100, 80 were found to be positive by Mando. Out of this 100 normal, 90 were correctly found to be negative by Mando. Is it clear? So naturally, I can write 20 here and 10 here. No doubt about it, right? Common sense. Okay. Now, these are my true positives. These are my true negatives, right? And I think it's time for me. These are my false positives. These are my false negatives. Okay. Now let's see what is sensitivity, specificity, positive predictive value, negative predictive value. Let's start with sensitivity. What is sensitivity? Listen. Sensitivity means the ability of your screening test to detect all those who have the disease from the diseased population. So while calculating sensitivity, in the denominator, you put all those who were having disease, all those who actually has the disease. Among them, how many were correctly picked to be having the disease by your test is sensitivity. Okay. Then what is specificity? Listen. Ability of your screening test to correctly detect all those who do not have the disease from the non-diseased population. So while calculating specificity, in the denominator, you put all those who do not have the disease. Among them, how many were correctly picked to be not having the disease by your test is specificity. Okay. Is it clear? Then comes positive predictive value and negative predictive value. This PPV is positive predictive value. Positive predictive value. Now, what is it? As the name indicates, positive predictive value means, as the name indicates, out of those who were predicted to be positive. How many were predicted to be positive? This 90 were predicted to be positive, which actually includes those who have the disease as well as those who do not have the disease. That means true positives as well as false positives, right? Among them, how many are actually having the disease? So, while calculating positive predictive value, in the denominator, you put all those who are predicted to be positive by the test. Among them, how many are actually positives? That is positive predictive value. Then what would be negative predictive value? Out of those who were predicted to be negative by the test predicted this one time to be negative, right? Out of them, how many are actually not having a disease? How many are actually not having the disease? 90 into 100. So this is how you calculate sensitivity, specificity, positive predictive value, and negative predictive value. In terms of A, if I put A, B, C, D, I hope you are able to see this. There comes the next MCQ. Even without looking into this, you can say, what is sensitivity? A divided by A plus C. What is specificity? D divided by B plus C. A plus C, B plus C, right? So D divided by B plus D. Then what would be positive predictive value? A divided by A plus B. Negative predictive value would be D divided by C plus D. Each of this is an MCQ. Okay, so that finishes a very tough topic, but small topic in your PARK textbook. And let me tell you, this is a very, very, very important topic. If you had gone through previous question papers, you might have seen at least 2 questions from this every year. By the way, let me check. Oh, Dr. Win, you have written so much. You're right. You're right. Absolutely right. I really appreciate. Even I don't have the patience to write this much. Good, good, good. You're correct. Okay. Now, what is validity? Next MCQ from this chapter. Validity means ability of your screening test to detect what it is supposed to detect. For example, if my blood pressure is say 120/80, if that sphygmomanometer can correctly detect my BP as 120/80, then only I can say it is a valid BP apparatus. So ability of the test to detect the truth is validity. By the way, there are two types of truth, right? Which are they? True positives and true negatives. That means there are 2 components coming into validity. That is the next MCQ. Which are they? There are 2 components coming in validity. Next MCQ. Which are they? Sensitivity and specificity. These are the 2 components coming in the validity. Next MCQ. Validity is also known as accuracy. The ability to detect the truth. That means how accurate is your result. So it is also known as accuracy. And I have seen one MCQ. Validity includes all except. One was accuracy, one was sensitivity, one was specificity, and one was something else. That was the answer. All except. Except was that 4th one. Okay. I don't remember what exactly. Anyway, something beyond all these 3. Then comes the last one from this chapter. What is reliability? What do you mean by reliability? That is something that we normally use in our conversation, right? Is he reliable? Is he reliable? Reliable means, will he always remain like this, or is there a chance that he may change after some time? So what is reliability? When you're repeatedly applying that test, will it always give the same result? Okay, yielding same reading or value when repeated under same condition. Okay, so that is reliability. So you have to remember what is sensitivity, what is specificity, what is positive predictive value, what is negative predictive value, what is validity, and what is reliability from this chapter. And that closes our chapter 4. So chapter 4 is also over. Now comes a very, 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 very big chapter, 5, 6, 7. Epidemiology of communicable, non-communicable, and national health programs. So let's start with the first one. So which is the program that we are going to start, or which is the disease that we are going to start? HIV. By the way, are you guys there? I'm thinking, okay, you are there, right? Are you understanding? Say something. Or am I simply talking? Okay, thank you, thank you. Okay, so that gives me a boost to move forward. Okay, very good. Thank you, SF. Nilesh, great session. Mark, 222, please extend classes. Go little, don't ask me to go a little slow, man. You know how big that PARK textbook is, right? I really want to go slow. I think I'm talking in 2x speed. So you don't play 2x here, okay? Because I'm already in 2x only. I mean, once the session, suppose the session is there, out there, you don't have to use a 2x speed here. Even otherwise, I'm talking very fast. Okay, coming to NACO. Let's start with the diagnosis. First question, where do you diagnose HIV? ICTC, first MCQ. Next MCQ, what is the full form of ICTC? Integrated Counseling and Testing Center, where you are giving counseling for the patient and then you are doing the testing. Okay, pre-test and post-test counseling. Next MCQ, how many tests you do? How many tests you do for detecting HIV? Okay, let me wait for the answer. How many tests you do? It is, 3 tests. Very good. You do 3 tests. Now, let's see, how do you diagnose in children? How do you diagnose this in children? In children, there is a test known as dried blood spot test. It is an early infant diagnostic, EID. It's an early infant diagnostic test which can diagnose HIV in children as early as 6 weeks of age. Okay, which can diagnose children as early as 6 weeks of age. Okay, This is also an MCQ. And right blood spot test is a DNA PCR technique. That is the next MCQ. It is a DNA PCR technique. Are you with me? Okay, each of this is an MCQ. So that was regarding the adults. Here it is about diagnosis in children. Now coming to the ART guideline. So after diagnosis, you have to give treatment, right? So let's start with the ART guideline. You will start, when do you start treatment for HIV? Irrespective of CD4 count. That is the first MCQ. That means you don't have to look into the CD4 count at all. Just start the treatment if the patient is found to be positive. Next, which are the drugs that you give? What I'm going to give you is the latest regimen. It is TLD. That means tenofovir, lamivudine, and dolutegravir. You just remember TLD. Earlier it was TLE. Okay, earlier it was TLE. Now it is TLD. Tenofovir 300 milligram, lamivudine 300 milligram, and dolutegravir 50 milligram. Next MCQ. How long will you give treatment? Anyone? How long will you give treatment? Am I the only person who is any CD4 count? I'm asking any CD4 count. No CD4 count, irrespective of CD4 count. Lifelong, Ronak. Very good, very good. Dana, very good, very good. It is lifelong. It has to be given lifelong. That means once you put the patient on ART, there is no stopping. Unfortunately, you have to give it. Like you are treating any other lifestyle disease, here also you are giving it for lifelong. Okay. Now coming to ART in pregnancy. Very, very important. And this was a previous MCQ. First question, when do you start? Is it in first trimester, second trimester, or third trimester? Again, you have to start at the earliest. You have to start at the earliest. Wait, let me change the color. I think B is not that visible. At the earliest. Second question, which are the drugs? Same TLD. We have only one drug, TLD, tenofovir, lamivudine, and dolutegravir. Don't think anything beyond that. Okay. For how long? Here also the answer is lifelong. I'm just showing the MCQs, guys. Okay. I'm just giving you the MCQs. Next, ART guideline in baby. Suppose a neonate is born for an HIV positive mother. Which is the drug of choice? First question, which is the drug of choice? Oh, 10 chats are pending. Nevirapine, Dara, very good. Nevirapine. You give Nevirapine 2 mg per kg once daily for 6 weeks. Okay, once daily for 6 weeks. Now, why only for 6 weeks? Because at the end of 6th week, we have a new test. What is it? We have a DNA PCR test, which will help to detect the baby as either positive or negative. If the patient is found to be positive, that means if the baby is found to be positive at the end of 6 weeks, then you have to, see, this is prophylaxis, right? This is prophylaxis. Whereas if the baby is found to be positive at the end of 6 weeks, then you have to give ART. So the next MCQ is, which is the ART that you give in children? It is zidovudine, lamivudine, and raltegravir. This is the next MCQ. The prophylaxis is nevirapine, and the treatment that you give as ART in children is zidovudine, lamivudine, and raltegravir. Okay. Now comes a very important MCQ, which came in last INICT. Okay, last INICT means which came 8th May, right? Yeah, in that there was a question regarding the prophylaxis, ART prophylaxis in neonates and its relation to breastfeeding. Seriously, that was the question that came. Okay, now let's see. So since we already got that question, let's see how is it related. Listen, guys. See, how long you should be giving this prophylaxis depends on whether it is a low risk baby or high risk baby. Okay, I'm not going to tell you what is low risk. See, low risk baby means a mother has taken adequate ART during her antenatal period and there is viral suppression, whereas high risk is the opposite. Okay, anyway, leave it. If it is a low risk baby, it depends whether it is exclusive breastfeeding or exclusive replacement feeding. You have to give this prophylaxis only for 6 weeks. Is it clear? Exclusive replacement feeding means the mother is not giving breast milk, instead she is giving some formula milk or something else. Whereas if it is a high risk baby, then if she is giving exclusive replacement feeding, there is no risk of HIV transmission through breast milk. You just need to give it for 6 weeks. Whereas if she is opting for exclusive breastfeeding, then you have to give drugs for 12 weeks. Are you with me? So this was the question which came in INICT exam in May 8th, 2022. So you can expect the same. All are, all the questions are coming from same source only. So you can expect something like this. I hope you're with me. Did you understand, guys, or did I actually complicate things? Wait, did you understand this? This particular table I'm asking. Okay, Dr. Win. Take a snapshot of this. Okay, Avinash. Thank you. Good. Now, moving on to post-exposure profile. I suppose someone got a prick from a patient. How will you go about next? You have to first test before starting the PEP. You want to know whether this person is already HIV positive or not. Then you have to start PEP. First MCQ, when to start PEP? First MCQ, when will you give post-exposure prophylaxis? At the earliest. That means, if possible, within 2 hours, but not beyond 72. That means you have to start it at the earliest, if possible, between 2 hours to 72 hours. After 72 hours, it will not be that effective like you are expecting. Next MCQ, which is the drug that you give in post-exposure prophylaxis? Same TLD, guys, same TLD. Next MCQ, how long will you give post-exposure prophylaxis? You can't give it for lifelong, right? So how long will you give? During your internship, at least 1 or 2 might have come across this post-exposure prophylaxis. How long? It is for 28 days. That means 4 weeks. Each of this is an MCQ. Shall I move on to the next? Okay. When is World AIDS Day? December 1st. This year's. I'm not saying this year's. This year's is not yet out. So you should be knowing last year's World AIDS Day theme of 2021 was End Inequalities, End AIDS. This slogan is important because this came as a question in 2019. Not only in 2019, in 2015 also there was a question. What was last year's World AIDS Day theme? So every year you can expect that. End Inequalities, End AIDS was this year's slogan. This year's means the latest slogan. Let me check the chat. Yeah, I'll come to all of that, Sunny. I'm coming. Okay. Then comes HIV sentinel surveillance. Okay, sentinel surveillance is done. First MCQ. It is done not every year. It is done once in 2 years, biennial. HIV sentinel surveillance is done once in 2 years. First MCQ. Second MCQ. It is done in AIDS population. Third MCQ. How many tests you do? Are you only testing HIV? No, you're testing 4 diseases, which are HIV, syphilis, hepatitis HBV, and HCV. Okay, so you're testing for 4 diseases. Next MCQ. Which are those 8 groups? Very, very important. This was a previous MCQ. This was a previous MCQ. Among all the following, except one, are the groups which are kept under surveillance in HIV. Someone is asking some question. Shika. Yeah, Shika, what is your doubt? Ma'am, please again. Which one, Shika? Which one? Okay, shall I continue? Okay, so 8 population are, first one is pregnant women. They are actually taken as proxy of general population. They are taken as proxy of general population. Then we have female sex workers, male sex workers, injecting drug users, and transgenders. These are the high-risk groups. These are the high-risk groups. Then we have 6, 7, 8. Single male migrant, long-distance truckers, and inmates of central prison. They are known as the bridge population. They are known as the bridge population. So out of these 8, 1 is proxy of general population, 4 are high-risk groups, and 3 are bridge population. Bridge means, they are acting as a bridge between the general population and the high-risk group. Are you understanding? So who are the bridge population? Who are the high-risk group? Who are the proxy of general population when it comes to HIV sentinel surveillance is an MCQ. Okay, shall I move on to the next? Coming to STD. For STD, we have syndromic approach, right? And here, based on some signs and symptoms, they'll be put into some syndrome, and we have some pre-packed color-coded kits, right? And each of this color and kit number is an MCQ. And I have seen students trying to mug that. Now, I can give you, see, these are the color-coded kits. And if you're interested, I can give you a small mnemonic. What do you see here? What is the color of, what do you see here? And you can tell me, right? What are you seeing here? Ma'am, last slide. Red, yellow, red, yellow. Okay, red, yellow, girls, right? Okay, red, yellow, bag. Good, good, good. Okay, so keep this picture in your mind. And this is the mnemonic. Great girls won't buy red, yellow bag. Okay, great girls won't buy red, yellow bag. So great is gray, green, white, blue, red, yellow, blue. So this is your kit. 1, 2, 3, 4, 5, 6, and 7. So that covers your MCQ. Now let them ask anything, you will be able to answer, right? Okay. So these are those kits which you can refer later. Now coming to UIP. Next important national program, UIP. So let's see what is new in, I know you are unable to read this, but I'm just showing you this table is very important in your Park textbook. Okay, this has all the latent updates included in a table. So if possible, you go through that textbook. Now, let's see what is new. What is new? Now we don't give tetanus, right? We are giving TD instead. That is the first MCQ. We are giving TD instead. Second, we have pentavalent, right? Pentavalent is not new, but it is a commonly asked MCQ. First question, pentavalent is given for, it is given 6, 10, and 14. So that everybody knows. This is given only up to 1 year. Penta can be given only up to 1 year. Next MCQ, which are the other vaccines that can be given only up to 1 year? Penta plus Rota plus IPV, only up to 1 year. That means if a child is coming after 1 year, don't give Penta. Instead, you have to give, that means after 1 year, you have to give DPT. Is that clear? But even though I said like that, there is one more clause added. If the child has already started taking either Penta or Rota or IPV in the first 1 year, forgot to take the rest, and again coming after 1 year to take the rest of the doses, then you continue the dose, which was the last exam question. Okay, hope you are with me. Coming to Rota, given on 6, 10, and 14, right? That is the first MCQ. Next MCQ, how will you give Rota? It is given as oral. Now, what is new in oral? See, earlier we were giving 5 drops, right? Whereas now we are giving it as 2 ml. What you see here is the latest pack of it is available as a pack. You can just flip it open the right cheek of the baby and instill this inside the right cheek. So it is given as 2 ml, which is new. Okay, the new latest pack that you see. Now coming to MR vaccine. Earlier it was measles. Now we are giving MR 1 and 2, right? 1 is given at 9th month, 2 is given after 16 to 24 weeks, right? So, okay, sorry, 16 to 24 months. Sorry, months. That means after 1.5 years. Okay, next MCQ. Where do you give MR vaccine? Right or left? It is given on right. Which are the other vaccines that are given on right? It is IPV and measles. So you can remember this mnemonic. I'm again giving you one mnemonic to remember few MCQs. What is happening? Wait. Okay. Now comes the next. You can remember MRI. What is it? Measles, MR vaccine, and IPV are given on right arm. Are you understanding? MR vaccine and IPV are given on right arm. Whereas, then comes the next question. Which are the vaccines that you give on left, upper arm? Those are JE and BCG on left upper arm. And how do you give JE? Just like you give MR, right? 9th month and 16 to 24 months. Now comes the new one. We have PCV 13 now, right? Okay, it is given as I think I don't have to tell you, 0.5 ml given as intramuscular dose. And what is the schedule? It is given on 6, no 10, 14. Just like you give IPV, 6 week, 14 week, and a booster dose on 9th month. Okay, this is how you give 6, 14, and a booster dose of 9th month. So this is the schedule of PCV. So we have covered all the vaccines. Even that is covered. Now coming to National Vector-Borne Disease Control Program. First MCQ is what you see here, the logo of NVBDCP. Next MCQ, which are the diseases coming under NVBDCP? Malaria, filariasis, dengue, Japanese encephalitis. What you see here is, what is this? This is leishmaniasis. Okay, post-Kala Asar dermal leishmaniasis is what you are seeing here, like nodules over the skin and chikungunya. So this is the next MCQ, the diseases which are covered under NVBDCP. Now let's see malaria. Am I saying BCG, JE? Good. Okay. Now let's see the treatment of PV and PF. Very, very, very important. Okay. Please listen carefully. Plasmodium vivax. Drug of choices are chloroquine and primaquine. Chloroquine is given for 3 days. On day 1, 10 mg per kg. On day 2, 10 mg per kg. And half of that on day 3, which is 5 mg per kg on day 3. Now, what about primaquine? Primaquine is given as 0.25 mg per kg for 14 days. Now, may I know why it is given for 14 days? Because you know that Plasmodium vivax is well known for relapse. So, these hypnozoids will be hiding inside the liver and they can come out and give relapse at any time. So, to remove all the hypnozoids, you are giving primaquine for 14 continuous days. Is it clear? So, that is about PV. Now, what is the treatment for PF? Drug of choices, ACT. What is ACT? Next question. Artesunate combination therapy. That means along with artesunate, what is that combination? Sulfadoxine, pyrimethamine. So artesunate is the anti-malarial. So like you give chloroquine, here also you give it for 3 days. And sulfadoxine, pyrimethamine in SP combination on day 1 alone. SP is given on day 1 alone. Now what about primaquine? Here, in PF, you don't have any relapse, right? So you don't have to give it for 14 days, just give 1 day. Okay, but 3 times the dose of what you're giving for PV, which is 0.75 mg per kg on which day? On day 2. Because on day 1, we are already giving artesunate, sulfadoxine, pyrimethamine. Now don't try one more. Okay, so go to day 2. You give primaquine on day 2. Is that clear? So this is the treatment for PF. Now comes a question which came 2 years back. What you see here is Northeast, right? And you know which are the Northeastern countries, states, right? So think about all those Northeastern states and anyone who is coming from any of those areas, the problem is they have already developed resistance to this ACT-SP. So for them, we have another choice, which is ACT-AL, artemether lumefantrine. And have you seen artemether lumefantrine? This is the drug box of artemether lumefantrine. Okay. Next, what about combined infection? For combined infection, that means the patient has both PF plus PV. So you have to treat both. What is the drug of choice for PF? It is ACT. Now, what is the problem with PV? Relapse. So there you have to give ACT plus primaquine for 14 days. Is that logic clear? You're treating both with the most important drug. Okay. And then comes malaria in pregnancy, which was again a previous MCQ. See, I'm only telling you about previous MCQs. Okay. So for Plasmodium vivax, you give chloroquine. It is PF. First trimester, you give quinine. Second and third only, you can give ACT. If it is PV, don't give primaquine. That is a point that I want to tell you because primaquine is contraindicated in pregnancy. So if it is a case of PV, just give chloroquine alone. Don't try primaquine there. For PF, first you give first trimester, you give quinine, and then second and third, you give ACT. That is fine. Now comes the last question from malaria. If it is a case of complicated malaria, how would you treat? The complicated malaria, the problem is mostly the patient will be having cerebral malaria. So the patient is not in a state to take anything orally. So there you have to start treatment with, you have to give parenteral treatment, either with quinine or artemisinin derivative. Doesn't matter. The point is, for the first 24 to 48 hours, you have to give parenteral treatment, either with quinine or artemisinin. After that, once the patient start tolerating oral drugs, then you can switch over to the oral treatment. Is it clear? So this is how you treat malaria. So we have seen different scenarios in malaria. Moving on to TB. TB is an ocean. Okay, if you get time, you can refer my class. It's a huge topic, but let me summarize all the important updates. Okay, in TB, a lot are there. Now we have daily regimen. Don't you know that? Okay, let me check your chats. IV artesunate, ACL, ACTAL. Good. So those were the previous questions, right? Okay, good. Are you with me till here? HR is ready. Oh, Ronak started. Are you with me, guys? Okay, so let's move forward. Okay. Now we have, like I said, now we have daily regimen. Second, all drugs are fixed drug combination. That means, like you said, HR is a D. They are not given separately like earlier. Now all these are combined into one single tablet. Third, now there are no treatment categories. Do you know that? Are you aware of that? We don't have any treatment category. See, earlier we were having treatment category 1, category 2, right? No, any old patient will go to category 2, new patients will come to category 1, assuming that they will not respond to, first line of treatment, or they are put to category 2. See, all those were based on assumption. Now, the point is, each and every patient who's coming to our system will be checked for all the major drug sensitivity. That means all the major ATT will be checked on them or will be tested on them to know about their drug sensitivity, and we are giving them a separate sort of regimen. Okay, so there is no treatment category. Fourth point, we have 2 new drugs, bedaquiline, dilamanid, and one more is there. You know what? Pretomanid. So I would say now we have 3 new drugs under TB treatment. Fifth point, no injectables. Earlier, we had HRZDS, right? Now, it is said that all injectables should be removed from the TB treatment because people, the complaints of patients to injectables are less. So, patients are asked not to, the system is, that means our program is saying not to give any injectable as far as possible to any of the patients. So, no injectables. Then we have newer technologies like 99 Dots, Nikshay. You know what is Nikshay, right? Nikshay is a web portal where you're entering all the details of the TB patients, whereas 99 Dots is actually a mobile app to ensure that the patients are taking treatment. You can refer my class. Then we have Nikshay Poshan Yojana. So what is Poshan? Nutrition, right? So this is a nutritional support given in the form of money, where each and every patient is given on treatment. Okay, each and every patient on ATT is given ₹500 per month, which came twice in previous exams. Okay. Then we have active TB case finding. When you were doing your MBBS, maybe we had only passive case finding. Now we have active case finding. That means you're going into the field searching for signs and symptoms. Then we have intensified TB case finding, where you are trying to find out TB in some other clinical settings, like, NCD clinic. If a patient is found to be diabetic, chronic diabetic, then you test them for TB. Then in post-COVID clinics, if a patient is coming with cough, you also suspect not only COVID, but also TB. So this is intensified TB case finding, where you're trying to find out TB in other clinical scenarios. And the last is, now we have latent TB case finding. Okay, so latent TB means the TB bacilli will be dormant and you are trying to find out TB in those even without signs and symptoms. Now the MCQ from latent TB, which had already come in the past exam, was, which is the test that you do in latent TB case finding? I'm waiting for your answer. Which is the test? Where is Ronak? Satya? Shika? Guys, which is the test that you do? Which is the test? Sputum. No, IGRA. Vicky, very good, very good. It is IGRA. The test is IGRA. The test that you do in latent TB is IGRA. IGRA. interferon gamma release assay. The next MCQ is IGRA is done on whole blood. All others are done on sputum, whereas this is done on whole blood. Both these are previous MCQ. Latent TB is found using IGRA, and IGRA is done on whole blood. Okay. Nikshay portion that we have already discussed. Now, this is 2022 World TB Day theme. Okay, when is World TB Day? Can you see? On 24th March. And this year's 2022 theme is Invest to NTB, Save Lives. Invest to NTB. Because now from 2021 onwards, we are investing only on COVID, right? So as a result of which, TB is kind of neglected and TB cases are coming up now. So the program says you invest in TB as well so that we can save more lives. TB is more problematic than COVID, but we are not realizing it. That is a problem. Okay, so you invest in TB to save lives. And this is the image-based question. This is the new logo of our TB program. By the way, what is the name of new TB program? It is not RNDCP anymore. What is the new name? It is NTEP, right? National TB Elimination Program. Okay, National TB Elimination Program. It is not RNDCP anymore. That is the next update. It is NTEP. And what is the slogan? What is our theme? TB Mukt Bharat. And the slogan is TB Harega or Desh Jeetega. Okay, so this image-based question you can expect as an MCQ. So we are done with TB as well. Moving on to, it's written there. I know it's written there. But when you get an MCQ regarding the image, don't expect that it will be written there. It won't be written there. Okay. Now coming to RCH, Reproductive and Child Health. This is the MTP kit. This is the MTP kit, which was a previous MCQ. In MTP kit, which are the drugs? You have mifepristone 200 milligrams. Can you see? Mifepristone 200 milligram and misoprostol 4 tablets of 200 microgram each. And how do you give this? The question was about the drugs. Mifepristone is given orally, and then misoprostol after 24 hours, you are inducing pervaginally. Okay, so that is about MTP kit. Moving on to next. What is this? This is free days. Now, what is free days? These are the sanitary napkins given for adolescents through our program. Okay, RMNCH plus A. Okay, so this is, the name was a previous MCQ in FMGE last year. Free days. This came as one of the options, if I remember correctly. So this is the name of the sanitary napkin. It is free only in name. Okay, it is free only in name, whereas you have to pay for it. Are you able to read it? ₹6. And inside that, there will be 6 sanitary pads. So cost of one is ₹1. Then comes a very frequently asked one, Nishchay. What is Nishchay? Nishchay is, yes, the urine pregnancy test kit. It is Nishchay. As the name indicates, Nishchay means to confirm. What is Nikshay? Nikshay is TB portal. That is NIKSHA. Shaya. Shay. This is Nishchay. Okay. Look at the spelling difference. This is Shaya. Shaya. Nikshay. Now coming to Pradhan Mantri Madritva Vandana Yojana. As the name indicates, Pradhan Mantri Madritva Vandana Yojana means it is something, it's an amount that we are giving as a respect, as a vandana towards all the mothers. So it's a maternity benefit scheme under which you are giving. First MCQ. How much amount are you giving? Anyone? How much amount are you giving? Okay, here comes the answer. Let me check. 5,000. Very good. 5,000. I see so many other questions. I'll come to that. Okay. At the end, I'll give you my mail ID as well and my Telegram address so you can log in. Yeah, it's 5,000. Very good. Everybody is answering it correctly. Okay. And you will not get this 5,000 as a number. So 5,000 itself is an MCQ. 5,000. Okay. You will not get this as a number. It will be given as an installment of 3. Now let's see which are those installments. First installment she will get after early registration of pregnancy. She's given 1,000 rupees. Then 180 days after her pregnancy, after doing minimum one antenatal checkup, she will get another 2,000. And the third is after delivery, after completing child registration, and after the child is given the first cycle of immunization, she will get the next 2,000. So this is how you give this 5,000. Okay. Next MCQ. Okay. It is also known as Pradhan Mantri Pregnancy Aid Scheme. And this is the logo. And logo itself is an MCQ. This is also an MCQ logo. Ma'am, all program name is in Hindi, feeling sad that you're from South. Come on. Hindi is our national language. Whether you're in South or North, you're supposed to know Hindi, right? Anyway, it's all coming from the national level. So naturally, that will be Hindi only. So this is Madrittu Vandana Yojana. Sorry. This is the logo of Madrittu Vandana Yojana. Okay. See one mother and one baby on the lap. Next is Janani Shishu Suraksha Karyakram. Since you said you are not understanding Hindi, now let me tell you. As the name indicates, Janani means mother. Shishu means baby. There is nothing to mug up. If you just analyze these names, automatically you will come to know what are the services given. So Janani Shishu Suraksha means protection. So it's a Karyakram for protecting the health of mother and the child. So what is the benefit they are getting? All services are given free. Okay, everything is given free, right from diagnosis through the management. If she requires, LSCS, everything is given free. Not only for mother, even for the baby, it is free. Even if the baby is in an ICU, that will be taken care of by the government. Okay, and the MCQ which came last year was free service to the baby under Janani Shishu Suraksha Karyakram is given for 1 year. It is for 1 year, up to 1 year. Earlier it was up to 31 days. Now it is for 1 year. Is that clear? So this is a previous MCQ. So the child is given free service through JSSK up to 1 year. Now comes Lakshya. Lakshya. What you see here is the logo of Lakshya. They always write Q in a different color and little vibrant and little bigger, because here Q is given some importance. What is it? So Lakshya is all about improving the quality of care in labor rooms. Quality of care in labor rooms. So that is Lakshya. And what you see here is Lakshya ka logo. Then comes Rashtriya Bal Swasthya Karyakram. As the name indicates, as I always say, as the name indicates, Rashtriya means national, Bal means children, Swasthya means health. So it is a Karyakram for health, for protecting the health of all children, Bals, from the age group 0 to 18 years. That is the first MCQ. Age covered is 0 to 18 years. Next MCQ, it is also known as child health screening and early intervention services. Okay, so all children between 0 to 18 years are screened for, very, very important MCQ, 4 Ds which are privileged in children. So comes the next MCQ, which are those 4 Ds. At least give me 1 D. 0 to 18, Thana, correct. Quality of care, labor room. Good, good. Everyone knows all the answers. Defects. Gautam, correct. Defects. Dhana, correct. Okay. I'm so happy that you are answering it correct. Whenever I ask this in class, you know what students say? Diarrhea, then dermatitis, death. These are the Ds they usually give. Good, good. Diseases in children. Very good, very good. That means you know. This is really a revision. I'm happy that you have all gone through those topics. Okay. Defects at birth, like, cleft palate, Down syndrome, neural tube defect. Then diseases in children like skin disease, then caries, otitis media. Then deficiency conditions in children like vitamin A deficiency, vitamin D deficiency. Then developmental delays like, visual impairment, learning impairment, ADHD. So these are the Ds that you are screening in children who are between 0 to 18 years. So that is our RBSK. And what you see here is the RBSK. Okay. And if you want to know which are the diseases, go through this after some time. Okay. So you can either take a snapshot or somehow you can remember this. So moving on to, I think, the latest update, Ayushman Bharat. What is Ayushman Bharat? Earlier we were having something else. Okay, now the national program, the universal health coverage we have in India is coming under Ayushman Bharat, which is Pradhan Mantri Jan Arogya Yojana. This is the health insurance we have. National Health Protection Mission is another name of PMJ. This term you might have definitely seen. PMJ, Pradhan Mantri Jan Arogya Yojana, which is the universal health coverage we have in India. Okay, okay. Okay, it's not a national language, ma'am. You should know that, please. Okay, I'm not going into those controversies. Spare me here. Okay, okay. Okay, so I quit. So he's saying that there should be, but at least we have to depend on one language, right? Okay, National Health Protection Scheme. 15 lakh. No, not Vicky. It is not 15 lakh, but 5 lakh. So, this is the universal health coverage. Now, how does it operate? We have some PMJ e-card. Okay, this is the e-card where you have the, it is a biometric enabled card where all the details of the beneficiary will be included. And how much amount are you giving through PMJ e-card? It is 5 lakh per family. 5 lakh per family. Okay, then what you see here is the logo of PMJ, Pradhan Mantri Jan Arogya Yojana. So what you see here are, you can see 5 leaves, right? Okay, so you can remember 5 lakh, something, I'm just trying to help you to remember this, this logo. Okay, so there will be 5 leaves or 5 petals, whatever. And you can remember, I can relate it to 5 lakh rupees. So this is Pradhan Mantri Jan Arogya Yojana. Not exactly like that, just trying to help you, okay? Now coming to the next disease. Modi ji promised 15 lakhs in every account, still waiting for that. You are pulling me into every controversy. What is this? What did I do? One person is pulling regarding the language, another person is pulling regarding something else. Let me finish this. I'm not running into all those. Anyway, okay, I'm keeping all those distractions out. Let's move on to the next. Crimean Congo hemorrhagic fever. So it is caused by a tick. And the name of the tick is the next MCQ. Picture of the tick is not important. Name of the tick is Hyaloma tick. Now comes the next MCQ, which came 3 times. Do we have it in India? Which of the following diseases we have in India? Was one question. So my question is Crimean Congo hemorrhagic fever or CCHF. Do we have it in India? Yes or no? Do we have it in India? Yes, we do have it in India. Okay, we do have CCHF in India. From 2011 onwards, we are getting repeated outbreaks of CCHF. So we have it in India. So next, which is this disease? This question, this particular picture came 3 times in various exams. Which is this disease? Not only in Rajasthan, it was there in Orissa, then it came in Gujarat in many places. Nipah, very good. Nipah, very good. This is Nipah. So I think I don't have to tell you. You see fruits, half-bitten fruits which have fallen down. Pigs are eating it. Then you see bats. So naturally, we are talking about Nipah. And we do have Nipah in India, right? Next MCQ. Which is the disease? There is a pregnant female. She's bitten by a mosquito. This particular picture came in, I think, last year. This one came. And the child is affected. Here it is written, Don't bother. It is Zika virus. That was not written. Okay. So this is about Zika virus. And Zika virus, see, Zika virus, if a normal person is getting Zika virus infection, just fine. But if it affects a pregnant woman, that can cause a very serious complication. It is possible to cause this very serious complication, which is that microcephaly in neonates, right? Okay. And do we have Zika in India? See, it is first reported in Rajasthan. After that, we are getting, cases of Zika in many places. So we have that as well in India. So the question which came in previous exam was all the following except one are the diseases that we have in India. I think in this INICT also we had that question. And the options were Zika, Nipah, CCHF, and yellow fever. So which is the one that we don't have in India till today? It is yellow fever. We have no yellow fever. Guys, please, we don't have any yellow fever, but all other diseases we do have in India. Okay. Now coming to congenital rubella syndrome, which is a previous MCQ. We are talking about communicable disease. Okay. In congenital rubella syndrome, which is the triad, eye, congenital cataract. Here, sensory neural deafness, and heart, PDA. Okay. So these are the three organs which are affected. Along with that, another very commonly seen thing is microcephaly. Even microcephaly is also very possible in congenital rubella syndrome. It is also possible in Zika. It is also possible in CMV. Okay, congenital cytomegalovirus infection. Okay, and the question which came 2 years back was microcephaly is seen in all the following except. So it is seen in Zika virus infection. It is seen in congenital rubella syndrome. It is also seen in CMV. Okay. So in all those three conditions, you see microcephaly. What is your diagnosis? Next image-based question. Ah, very good, very good. Hutchinson's triad that you see in. Good. Very good. Peck shape, right? Centrally nosed. Incisors, upper incisors that you see in. Yes, it is a Hutchinson's tooth. Mulberry molar. Okay, so these are the ones that you see in syphilis. So we are talking about congenital syphilis. And in congenital syphilis, what are the other things that you see? What is the triad that you see? One is teeth. Then again, what do you see in eye? Keratitis and sensory neural deafness. This is again from a previous MCQ. This was an image-based question. And the question was, which is the disease? Of course, you will, if you read this, you will find the disease, but only the pictures were given. Nothing was written there. Yeah, it is about leptospirosis. See, you see a mouse or a rat, then pool of water, puddle of water. And, leptospirosis spreads through the urine of few animals. Okay. So the MCQ that you should know from leptospirosis is gold standard test for leptospirosis is first MCQ, MAT, microscopic agglutination test. Next MCQ, drug of choice for treatment is penicillin, but we also give doxycycline, tetracycline, ampicillin, then amoxicillin and such things. Next MCQ is, which is the prophylaxis, chemoprophylaxis that you give for, people who are coming in contact with flood and people who are going for NREG, that 100 days of work. So for them, we are giving chemoprophylaxis, which is the chemoprophylaxis is a previous MCQ. Anyone? Are you not listening? Which is the chemoprophylaxis? Something went wrong. Cotrimoxazole. No, Vicky. It is doxycycline. Okay. So it is doxycycline. Next MCQ. Dose 200 mg. Next MCQ. How do you give it? Every week. Every week. Till the person is exposed to that risk. Okay. Doxycycline 200 mg every week, which is an MCQ. Chemoprophylaxis. Now coming to a previous MCQ, which came in this INICT 2022 as well. Okay. So this is regarding the treatment of leprosy. So when it comes to leprosy treatment, first you divide them into paucibacillary and multibacillary. Paucibacillary means 1 to 5 lesions and multibacillary is more than 5. That means from 6 and above. More than 5 is multibacillary. So this was a very controversial question. Okay, so for paucibacillary, what you give was the question. And for paucibacillary, see, let me tell you, what is given in your books? I don't know, in few guides they have said that for paucibacillary and multibacillary, we are giving 3-drug regimen. That is according to WHO guideline. Okay, whereas in India, under the program, we are giving some different regimen. Please listen carefully. For paucibacillary, like it is said in your PARC textbook, we are giving 6 months of this 2-drug regimen, which you see in green. Okay, this contains only 2 drugs. Okay, which are those drugs? You can see here, rifampicin and dapsone, given for 6 months. This is given for 6 months. Whereas for multibacillary, we are giving 3-drug regimen for 12 months. Whereas what is given in your books, I'm not talking about PARC textbook, what is given in your other books is WHO regimen, which we are not following in India. So the question which came in your last INICT was, what is a drug that we give for paucibacillary in India? In India, you're giving 2-drug regimen and not 3-drug regimen. Okay, and this is regarding children, so you can just see it's almost the same only. I just wanted to show you the color because the question which came in last INICT was an image-based question. They are given green multi-blister pack and this red multi-blister pack, and the question was which among this will you give? Okay, so I just wanted to show you this picture. Now coming to H1N1, very important for swine flu. Which is the drug of choice? Drug of choice for treatment is oseltamivir. Next MCQ. How do you give it? 75 milligram BD for 5 days. Okay. Next MCQ. Which is the drug of choice for prophylaxis? Same oseltamivir. Same oseltamivir. Same 75 milligram. Then what is the difference? It is given as once daily for 10 days. Did you get the difference? Both were previous MCQs. Okay, so treatment 75 milligram twice daily for 5 days, and for prophylaxis 75 milligram once daily for 10 days. Is it clear? Okay. Now coming to, so we are done with, communicable diseases. Moving on to non-communicable diseases. What you see here is the logo of National Program for Control of Blindness and Visual Impairment. See, there is a change in the name. Earlier it was National Program for Control of Blindness, right? Now they have added and visual impairment. So the name is new. The logo is old, but the name is new. Next MCQ. See, the definition of blindness under National Blindness Control Program has changed. The latest one is, I'm not telling you what was the old one. Blindness is visual acuity of less than 3/60. First MCQ, visual acuity of less than 3/60 is the definition for blindness. And they have also added visual impairment, right? So they have also a definition for visual impairment, which is visual acuity between 6/18 and 3/60. Is it clear? Okay. Now moving on to another very frequently asked question. Pap smear. Okay, let me check whether any chats are there. Once daily for 14 days, 3/16, better eye. Good. Okay, good. Pap smear. This question came 3 or 4 times in last 3-4 years. Okay, this is for cervical screening. That everyone knows. Next MCQ. When to start? When to start? You have to start it at the age of 21 years. That is the age that is prescribed. That means between 20 to 25 is fine. Between 20 to 25 is what the association is saying, but usually it started 21 years. Next question, how frequently you do? Each of this is an MCQ. Okay, each of this is an MCQ. How frequently will you do it? It is done every 3 to 5 years. Next MCQ, when will you stop? Till what age? Till 65 years. Each of this is an MCQ. Next. For preventing this, we have HPV vaccine, right? And HPV vaccine is given from 9 to 26 years, which is again divided into 2. 9 to 14 and 15 to 26. So up to 14 years, up till teenage, you can remember, you are giving 2 doses on 0 and 6 months. Whereas from 15 to 26, it is given as 3-dose series from 4016. Just like you are giving your hepatitis B, you give it as 3-dose 016. Is that clear? And this also was this year MCQ. That means INICT. MCQ. Okay. I was just checking the chats. Previous slide. Which one here? This one. I think this will be available in YouTube. So you can go back and you can always check. Okay. And coming to HPA approved vaccines. Now, let me tell you one thing. These are the vaccines that are available, but only Gardasil 9 is currently in use, which has got 9 zeros of HPV. Okay, HPV virus. And these numbers also, you please remember. Okay, due to lack of time, I'm not going into those numbers. So what we use now is Gardasil 9, which is a non-valent vaccine. And you should be knowing these numbers. It is working against which all serotypes. Now coming to chapter 8. What is the time now? Oh, it's 7. Do you want me to go forward? Please let me know. Okay, Sunny, your question is valid. Nowadays, we are using more of VIA because that is cost effective. We are using both, but if you get a question which is more cost effective, whether it is VIA or pap smear, go for VIA. Shika is behind PDF. Okay, coming to chapter 8, essential medicines. I think I'll take for another half an hour, right? Okay. Because you missed some slides. This will be available here in YouTube. Don't worry. Okay, coming to essential and counterfeit medicine. This is a new chapter that is added in your path. Okay, so it is chapter 8. And you believe it or not, in last FMGE, there was a question from this chapter. What is the criteria for inclusion of a medicine under national list of NLEM is national list for essential medicine? So there are some criteria for a medicine to be called as essential medicine. It should be approved in India. We're talking about the Indian. Always we are talking about the Indian standards. Okay, it should be approved in India. That should be for a disease which is of public health importance. Then there should be proven efficacy and safety. It should be cost effective. It should be in alignment with current treatment guidelines. It should be something which is in the current guideline. And it should be stable under storage condition in India. So these are the criteria for a drug to be called as essential drug. That is the first point. Each of this is an MCQ. We are not yet done. The price of total treatment should be considered. This was a previous MCQ. Fixed drug combination are generally not recommended. Only one-to-one drug. Okay. Then the drugs under NLEM are actually divided into P drugs, X drug, and T drug, depending upon whether they are, used as primary, secondary, or tertiary healthcare levels. Okay, so these are about the essential drugs. Then criteria for deletion of medicine from NLEM. When do you delete a drug from essential medicine? Once it is banned in India, even without me telling you, you can just guess using your common sense. Once we have concerns regarding safety profile, when we have a better drug which is much cost effective, then once that disease is no longer a public health problem, like we had smallpox earlier, but we don't have it now. So like that. Then if there is a resistance noted, again, you have to remove it from essential drug. Okay, so these are previous MCQs. So we are done with chapter 8. That was a small chapter. And counterfeit drugs, by the way, I didn't tell you what is counterfeit drugs. Counterfeit drugs are drugs which are produced with the intention to cheat people or cheat patient or cheat public. That is counterfeit drug. Under which we have misbranded drugs, some names are there. Now coming to chapter 9, Millennium Development Goal 2, SDG, Sustainable Development Goal. Upload PDF annotation in Telegram, ma'am. Session was good. I'm not yet done. Okay. I'm planning to go for another half an hour. So once I finish 10 chapters, I can be very happy. Okay, I finished at least 10 chapters. You don't have to worry about MDG because we are done with MDG in the year 2015, right? Now what we have is Sustainable Development Goal. So don't worry about MDG. So that is done in 2019. Sorry, 2015. And in 2015, we started the next one, Sustainable Development Goal or SDG. It was started in 25th September 2015. 193 countries participated. It is by UN General Assembly. And the most important MCQ is, all these goals are to be attained by the year 2030. We are in 2022 now, right? And we are planning to attain all these by the year 2030. So this 2030 is an MCQ. So when are you planning to attain SDG 2030? Now, how many goals? 17 goals, which is an MCQ. 17 goals is an MCQ. Now I'm going to show you a few more points, but they haven't come as MCQ. 169 targets are there. 304 indicators are there, which are not that important, but this is very important MCQ. Okay. Now comes the next MCQ from 17 goals. Out of all these 17 goals, I'm showing you all the 17 goals. You don't have to study all the 17 goals at all. 17 number is important, 20, 30 is important. And the next MCQ is, out of these 17, which is the one that is directly related to health? If you look at this, you know, which is the one that is directly related to health? The good health. Goal 3. That is the next MCQ. Goal 3 is related to health. This is the one that is related to health. So that covers all the important MCQs from that chapter. So we are done with chapter 9. Moving on to chapter 10, demography and family planning. Only previous MCQs we are discussing here. I have a tendency to look at the chats. Chats here, chats there. Hi, Mani. I was actually looking for you. I didn't see you in Zoom. So you are in YouTube. Good. My regular viewer. Okay. I don't know whether it's the same Mani. Okay. What is X ratio? Number of males per 1,000 females or number of females per 1,000 males? It is number of females per 1,000 males. Next MCQ. What is the sex ratio of India? What is sex ratio of India? What is the sex ratio of India? 945. It's 943. Very close, very close. You won't get close numbers. So even if you are remembering it as 945, it's fine. It's 943. Next MCQ, which is state that has got highest sex ratio? It is Kerala. 1084. That means more females than males, right? And lowest in Haryana, which is 877. Then one more thing I want to tell you. We have something known as child sex ratio. Wait. No. We have something known as child sex ratio. There the age group is 0 to 6 years. That is the next MCQ. And you can expect one more from child sex ratio. The number is 914. So again, you can remember like this is 940 and this is 914. Okay, 940 and 914. Yeah, very good. Very good, Gautam. Good. Well done. Sex ratio in India. This value is given in your PARC textbook, so I thought I'll mention that as well. If the question is according to SRS 2020, then you can go for 899. See, the number of females are coming down, right? What is happening to all these females? I wonder why it is coming down. Anyway, this is as per SRS 2020. But if you're simply getting sex ratio, go for 940. 2019 says 1021. But one problem with this is we need the reference. Okay, so this is the reference as per SRS 2020. Unless if you don't have any reference, you just can't go by what they are giving in net and all. Next MCQ is dependency ratio. By the way, what do you mean by ratio? Numerator different, denominator different, right? So what you see here is the picture of dependency ratio. So in the numerator, you have all the dependent people. So who are they? Small children and elderly, right? Small children, next MCQ. Small children, age group is 0 to 14. That means less than 15 years. Okay, less than 15 years. And then, wait, I have this. Huh? You have the age group 0 to 14 years in the numerator plus elderly above age group of 65. And in the denominator, you have all those who are economically independent. So the age group you have in between 15 to 64 years. So dependency, DR is dependency ratio and it's not dependency rate. Ratio means numerator different, denominator different. In the numerator, as you can see in this picture, you have children who are dependent and elderly who are dependent. And in the denominator, you have all those who can actually support them. Okay, so this formula is also an MCQ. And these age group are also MCQs, like young dependency ratio, old age dependency ratio. Now comes another frequently asked MCQ. If you want to stabilize the population of India, okay, if you want to stabilize the population of India, there are 3 criteria given. First one, total fertility rate should be equal to 2.1. That means per family, 2 children. Next, NRR, net reproduction rate. Net reproduction rate is number of girl children born by a couple. Should be 1. Third is CPR, couple protection rate should be more than 60%. So once we achieve all these 3, then it is said that we can prevent the population explosion and we can stabilize the population of India. Okay. Each of this is an MCQ. Trust me, previously asked MCQ. Now coming to demographic cycle. Now, by the way, what do you mean by demographic cycle? See, every country, whether it is developed or developing, they have to go through, as part of their evolution, they have to go through certain stages in its cycle, which are mainly 5 in number. And all these 5 are together known as demographic. These 5 stages are together known as demographic cycle. Okay. First MCQ, which are those 5 stages? Zaifa, ma'am, how are you? I'm fine, thank you. I hope you are also doing well. Okay. First MCQ, which are the names of those 5 stages? High stationary, early expanding, late expanding, low stationary, and declining. So these names are MCQs. Let's go step by step. Next MCQ. All these stages are described based on the shape of dash. Shape of demographic gap. So that brings you to the next question. What is demographic gap? Demographic gap is the difference between birth and death rate when you plot both birth and death on the same graph. See, along the y-axis, you plot birth and death rate. Along the x-axis, you plot time in years. And when you plot birth and death, I hope you are able to see me. I'll move a little backward. When you plot birth and death, this gap is demographic gap. And each of the stage is described based on the shape of the demographic gap. Now let's see the rest of the MCQs from each of this stage. Now, what is stage 1? I really want you to listen carefully. Please, just 1 minute. Give me your valuable attention. See, stage 1 was in pre-industrial era. In pre-industrial era, are you able to see birth rate was very high, death rate was also very high, but the number of births and deaths were almost equal in number. So this is high stationary. That means what is happening to the gap? Gap is stationary, but at a higher rate. Okay. Now, what is stage 2? Stage 2 was in early industrial era. In early industrial era, new medicines were discovered, hospitals opened up. So as a result of which, what happened? The number of deaths started coming down with number of births going as such. So this is early expanding. Okay. Now, what is stage 3? Stage 3 was in industrial era. In industrial era, family planning was introduced. So what happened? Number of births also started coming down with further decreasing number of deaths. So this is late expand. Okay. Next, what is stage 4? Stage 4 was in post-industrial era. In post-industrial era, what happened? Number of births were less, number of deaths were also less, but the number of births and deaths were almost equal in number. So what is happening with the gap? Gap is going stationary, but at a lower pace. This is low stationary. Now, what is stage 5? In stage 5, see, however you try, you cannot bring any further decrease in number of deaths, right? Everybody will die. So it is never possible to bring death to 0, whereas that is not the case with number of births. So in stage 5, what is happening? The number of deaths is going as such, whereas the number of births are going below the number of deaths. So more people are dying than being born. So that will lead to declining. Hope you are with me. Okay. So these are the 5 stages, and each of this that I have explained, what is happening to birth rate and death rate, is an MCQ. Hope you are with me. Did you follow? I know it was something, which requires a little bit of understanding, but I hope I made it simple. Did you understand? Dr. Vin, Dhana, where are you guys? Say something so that I can move forward. I stop by 7:30. Okay, thank you, Dhana, Satya. Okay, good. Please continue. Okay, I'm continuing. Now coming to family planning. So let's see what are the updates in family planning. Can you see these pictures? So all the updates in family planning, I have tried to compile in the form of one single picture. So, okay, all these I have combined in the form of one single picture. Now, what is this? This is Antara. First MCQ, what is Antara? Antara is, it's a new name for DMPA. It is dipometroxyprogesterone acetate. It is an injection given every 3 months, right? It's an injection that you give every 3 months. That is the first MCQ. From Nirod, it is a condom and there is nothing new in that. Next MCQ, we have Malayan. What is Malayan? It is oral combined oral contraceptive pill, right? We have 2 types, which are the Mala N and Mala D. Mala N and Mala D. Next MCQ, constitution in both are the same. Both contain ethinyl estradiol and levonorgestrel with iron tablets. Now, what is the difference? Difference is that one you get free, other you have to buy from outside. So, which is free? Mala N is free. So, you can remember, like, I don't know whether you are able to see this. N means, you can remember, no cost. Whereas D means दुकान से लेना है. Okay, that means you have to buy from shop. So D means दुकान से खरीदना है. So that way you can remember. Anyway, N means no cost or not for sale. That way you can remember. So this Mala N is the one that is given through EHCs and CHCs. That is why you see only Mala N here, whereas you don't find Mala D. Next. This is Chaya. Chaya is the new name for Centroman or Saheli. You might have heard about Saheli, right? So that is the new name. Chaya is the new name for Centroman or Saheli. Okay, that's it. Then Easy Pill. This is the emergency contraceptive pill. This is the emergency contraceptive pill. Is Easy Pill, not E-Pill, E-Z-Y. These are the names we have currently under the National Health Program. That means Family Planning Program. Okay. The very important MCQ, see earlier, the levonorgestrel were given as 0.75 milligram of 2 2 tablets. Now, this is combined into one, and we have only one tablet of 1.5 mg. One tablet of 1.5 mg, and that should be taken within 72 hours. That is the next MCQ. Moving on to the IUCD. You know, we have 2 types of IUCD currently in use under family planning program. Picture is also important. See, in all of these, the picture, image-based question you can expect. This is 380A. This is 380A. Copper T 380A. Whereas this is multi-load 375. See, property is 380A. Whereas this is multi-load. This is, don't think that if you get the picture of this, don't think that this is lippy slope. I've seen students answering this as lippy slope. This is not lippy slope, but this is 375. Now, what is the difference? The difference is, that is the next MCQ, 380A is for 10 years, whereas 375 is for 5 years. That is also an MCQ. Okay. And Nishchay, then tubal ring is available. You know, those things you know. Okay, it's a vaginal ring. So that covers all the recent MCQs and updates from family planning program. Okay, let me check your chats. 1.5 CDRA Lucknow. Okay, Saheli. Good. So that finishes all the MCQs from family planning. So we have covered almost half the chapters. Okay, by 7:30 I will stop. Hope you don't mind. Easy can be used. Yes. If I can be used within 72 hours. Now coming to chapter 11, preventive medicine in obstetric, pediatrics, and geriatrics, or your MCH. Okay, let's start with the prenatal. Minimum number of antenatal checkups. It is 4 according to our national program, whereas it is 12 according to WHO. The question which came in your last FMGE, 2021 FMGE was, no, December exam was according to WHO. It is 12. According to national program, it is 4. Okay. So these are the, sorry, not 12, 8. Sorry. It's 8. Okay. Starting with 12. So it is 8. Let me go back and little concerned about. Sorry. It is 8 according to WHO. Okay. So these are the 8 ones. Now coming to diet, antenatal diet. Let's see the latest guideline. During pregnancy, she's asked to, pregnancy, during pregnancy and lactation, the women are asked to take more of protein and calorie, right? And in pregnancy, she's asked to take 350 extra kilocalorie and 22 gram protein. Earlier it was 23, now it is reduced to 22 gram protein. Okay. And it is clearly said that the 22 gram protein that you give is, again, as per the latest guideline, it is said that for the first trimester, she doesn't require any extra. She doesn't require any extra protein. Whereas in second trimester, she's asked to take extra 9.5 grams. And in third trimester only, it will increase to 22 grams. Okay. So these are also MCQs. Now, what about this 350 kilocalorie? I mean, how will you ask her to take? I mean, what extra will you ask her to eat? If you ask her to take 350, she will not understand. So what extra will you ask her to take? Just one extra meal is required. Okay. What we normally use as meal is the 350 kilocalories. So just ask her to take one extra meal. This is very important because in India, especially in rural areas, I have seen that once the pregnancy is diagnosed, then your family members will be like, "Arey beta, you're not one now, you're 2. So you have to eat for 2 people." That is how usually family members, they advise. Now you're not 1, 2, so you have to eat for 2 people. Then she'll start eating for 2, 3 people, and they are putting on a lot of weight. That much is not required. She just need to add one extra meal. Okay. And what about lactation, which is again divided into first 6 months and rest of the 6 months, anyway, 6 to 12 months. And the first 6 months, exclusive breastfeeding, right? So she's asked to take almost double calorie of what she is taking for pregnancy. That means 600 kilocalorie and 17 gram protein. And in the next 6 months, 6 to 12 months, 520 and 13 gram protein. That is also actually easy to remember. See, 6 months, 6. Are you seeing 6, 6 here? 12 months, 6 to 12 months, 520. Is it clear? So you can remember this 6, 6, 12, 520. Is it clear? Now coming to antenatal immunization. The antenatal immunization that you give, which is a vaccine, TD. Don't write capital T. That is adult diphtheria content. This is, sorry, that is child diphtheria content. This small d is adult diphtheria content. Okay. First dose at the earliest. How many doses you give? 2 doses, right? That everyone knows. First dose at the earliest. Second dose after 4 weeks. Next MCQ. How long will it give protection? If you give 2 doses, how long will it give protection? It will give protection for 3 years. That means if she's again getting pregnant, within the next 3 years, she just need 1 booster dose. So the next question is, when will you give that booster dose? It is advised to give 4 weeks prior to her expected date of confinement. Okay, 4 weeks prior to, again, you can remember this 4 weeks. Okay, 4 weeks prior to her expected date of confinement for better antibody production. Okay. Now coming to iron folic acid, very, very important. Iron folic acid. This table you have to learn. This is the latest schedule that of iron folic acid that we are giving under Anemia Mukt Bharat. What is available in India currently is according to Anemia Mukt Bharat. And according to Anemia Mukt Bharat, you call it as National Iron Plus Initiative as well. So there we are giving it for 5 category of people. Okay, we are giving iron folic acid for 5 category. 2 are children. See, 2 are children. 6 months to 5 years and 5 to 9 years. 2 adults. 2 adults. Women in the reproductive age group and pregnant and lactating women. And in between, you have adolescent. In between, you have adolescents. That means 10 to 19 years. Okay. So you can think about that gradation. 6 to 5 years, 5 to 9 years, 10 to 19 years, then 20 to 49 years, pregnant and lactating women. Now comes the iron folic acid dose. Next MCQ. For the first 6 months to 5 years, you are giving 20 milligram of elemental iron and 100 microgram of folic acid. You know, earlier, for pregnant and lactating women, we were giving 100 milligram of elemental iron and 500 microgram of folic acid. Okay, so 1/5 of that. That means 20 milligram of elemental iron and 100 microgram of folic acid. For 5 to 9 years, you can remember, no, 5. So 1 number less, 4. So 45 milligram of elemental iron and 400 microgram of folic acid. So this 5 and 4, you can remember like this. Whereas from 10 years onwards, you are giving 60 milligram of elemental iron and 500 microgram of folic acid. For 10 years onwards, for everyone, you are giving 60 milligram of elemental iron and 500 microgram of folic acid. So this, each of this cell is an MCQ. Now, what about the frequency? For children, I mean, small children, up to 5 years, you are giving it as liquid formulation. It is given as syrup. So it is given bi-weekly. For pregnant and lactating women, those who have gone to labor rooms, you know, those who have worked or those who have taken duties, you know that we are giving it every day, right? Daily, 180 days antepartum and 180 days postpartum. Earlier it was 100. Now it is changed to 180. Next MCQ that you have to keep in your mind. 180 days antenatal, 180 days postnatal. Okay. Whereas for all others, it is weekly once weekly. So it is different only for the first group and last group, whereas for all others, it is weekly once. Now coming to the tablet color. For 5 to 9 years, it is pink. For adolescent, it is blue. Whereas for adults, it is red. That is also an MCQ. Okay. And if you are under doubt whether we are actually giving 60 milligram, because some textbooks so that in MCS you are not giving 60 milligram but 100 milligram. No, it is 60 milligram. This picture I took yesterday evening from my hospital. Okay, this is the government supply that is available currently. See, it is IFA as per Anemia Mukt Bharat. This is what we are giving for pregnant women in our hospital. 60 milligram of elemental iron and 500 microgram of folic acid. So I just wanted to show you that this is what we are giving. And for adolescent, see, one blue pill a week. We went from lazy and slow to always on the go. So it is blue pill. Okay. So we are done with antenatal. What is the time? Oh, it's 7:30. Shall we stop? What do you say? Shall we stop? I think we have covered. Can't continue like that. Okay, I'll cover this MCH and after that we'll stop. Okay. Once MCH is covered, even I can be very happy. If not today, I'll continue some other day. Okay. That is a deal. Huh? We'll cover MCH. Now, intranatal. Now, intranatal. So we are done with antenatal. Intranatal. What is the problem with intranatal? If you don't give proper care for the baby, of course, anything can happen. But from public health point of view, the one that is most important is, or the one that we are worried is about neonatal tetanus, right? If we don't give proper care during intranatal period, it can lead to neonatal tetanus, right? Just think, as long as we see, as long as the child is inside the womb of the mother, child is free of neonatal tetanus, provided the mother has taken the vaccines. Okay. But the moment the child decides to come out, we doctors and hospital will be waiting outside to introduce neonatal tetanus to the baby, right? If you think, you will realize that we are the ones who are giving neonatal tetanus to the baby. That means there are 5 levels in which we doctors and hospitals are likely to introduce neonatal tetanus to the baby. So for that, government or the program has specified 5 cleans. Okay. And these 5 cleans are for us. Okay. So let's see which are those 5 cleans. These 5 cleans are for elimination of neonatal tetanus. See, the first level where we are likely to introduce neonatal tetanus to the baby starts in second stage. In second stage, the mother is full. She's coming to stage 2. What is the first thing that you offer her, which can actually act as a source of Clostridium tetani? That is the delivery surface. Okay. So if the delivery surface is not clean, then it can give disease to the baby. So clean surface for delivery. Then clean hand. See, the moment now the baby is about to come out and the doctors are waiting with unclean hands. So second is clean hands. Now we have 3 more cleans, and all these 3 cleans are with the cleanliness of code. So while cutting, use something sterile. Then after that, while tying, you use something sterile, but that's not a problem anymore because we have, plastic clips which are available, disposable plastic clips. And after that, clean cord stump. That means don't apply anything over the stump, because in some places, in some states, they have the habit of applying cow dung, then ash, and so many things. Don't do anything like that. This 5 cleans is again replaced with, not replaced, 2 more cleans have been added to 5 cleans, which makes it 7 cleans. And these 2 extra cleans is for us doctors to ensure that our hands are clean. So what are these? Along with these 5 cleans, use clean water and use some clean towel for drying it. So we have 7 cleans for eliminating neonatal tetanus. Each of this clean is an MCQ. Now coming to postnatal. Postnatal breastfeeding, very, very important. First question from breastfeeding. When to start breastfeeding? At the earliest. Whether it is, cesarean section or normal delivery, you have to start it at the earliest. Next MCQ. Exclusive breastfeeding is for 6 months. No doubt about it. Next MCQ. How long should you give breast milk? After 6 months, you can, of course, start weaning, but breast milk should be given up to 2 years. That is the next MCQ. Now you have an image-based question. What is this? What is this? Okay, what is this? Image-based question. What is this? Yes, that is colostrum. Very good, very good. This is colostrum and this is mature breast milk. Okay, now let's see what are the differences between mature breast milk and colostrum. See, I'll only give you the MCQ which came in last FMGE question. This colostrum, when you look at this, this looks very thick, right? It is thick not because of fat, but because of protein. This has high concentration of protein, high concentration of antibody, high concentration of so many things, except two things. Which are they? Fat is less and sugar is also less in colostrum. Except these two, all other contents are more in colostrum. Okay, this was the previous MCQ. Colostrum compared to mature breast milk has got less fat and less sugar. Next MCQ is regarding the protein content. I said protein content is more. So protein content of breast milk is 1.1 gram per 100 ml, whereas in colostrum it is 8.6 gram per 100 ml. Sugarless, fatless, very good. Yes, colostrum is known as the first immunization of the baby. Very good. I usually say that, but due to lack of time, I just skipped it. This is a comparison between cow's milk and human milk. You don't need to know these numbers, guys. You don't need to know these numbers, just the MCQ. And the MCQ is only two things are more in human milk. Which are they? That is the MCQ. Don't remember these numbers. So we have combined colostrum and breast milk. Now we are comparing cow's milk and breast milk. Only two things are more in breast milk. Which are they? One is lactose or carbohydrate or sugar. And one more thing, which is that? Can you find it? Iron. Except lactose and iron, all other things are more in cow's milk. Of course, water, little bit of water, but they won't ask about that. Only two components are more in breast milk. Which are they? Lactose and iron. Whereas all others are more in cow's milk. And this is the last part from, okay. I think, okay. Now, moving on to, okay. Now coming to indicators, MCH indicators, mother and child indicators. See, mother and child indicators are very important and they're very sensitive, right? Any change will be first affected in mother and child. So let's see MMR. First MCQ from MMR. Mother is MMR. First MCQ, full form is maternal mortality ratio and not rate. Don't write MMR is maternal mortality rate. It is maternal mortality ratio. Second MCQ, what is the formula? See, this will tell you per 1 lakh live births occurring, how many mothers are dying. That means when 1 lakh children are born alive into a population, how many mothers are dying. So total number of maternal deaths divided by total number of live births into 1 lakh. That is the next MCQ. Third MCQ from MMR. What is the definition of maternal mortality rate? Maternal mortality or maternal death. Maternal death means a mother who is dying while she's pregnant or at the time of delivery or up to 42 days of termination of pregnancy. That is an MCQ. For how long? After delivery up to 42 days. But not from accidental or incidental cause. Not from accidental and incidental cause. That means, see, this is also very important. Suppose a mother is, a pregnant woman is dying in an accident. You can't call it as maternal death, right? Suppose she's committing suicide. You can't call it as maternal death. I hope the message is clear. Okay, but not from accidental or incidental cause. Okay, so these are the MCQs from MMR. Now coming to child indicators. So these are the 6 child indicators. Now the MCQ is regarding the numerator and denominator. Not only the, now let me tell you which are the MCQs that you can expect. These indicators names are MCQs. Then the formula are also MCQs. And you may get problem-based question where you have to substitute some values. Okay. Now let's see. If you give me 1 minute, I can explain to you. Okay, 2 minutes. In 2 minutes, I can explain to you what is the numerator and denominator, each of which is an MCQ. Let's talk about denominator first. In all these, except the one which has got number, the denominator is, in all this, I repeat, in all this, except the one which has got number, the denominator is total number of live births. Total number of live births. So in all except the one which has got number, which is that one, 1 to 4 year mortality rate. In all others, the denominator is total number of live births. So that brings you to the next question. What will be the denominator of 1 to 4 year mortality rate? Here the denominator is number of children in the age group 1 to 4 years. Okay. Child mortality is under 5. Okay. This is under 5 mortality rate. Hope you're with me. So here, only in this, you have the denominator as total number of children in the age group 1 to 4 years. Whereas in all the others, denominator is total number of live births. Now moving on to numerator. For numerator, I have a picture. See, this is the numerator. Okay. Just listen. What do you mean by infancy? 0 to 1 year is infancy, right? 0 to 1 year is again divided into 1 month and rest of the months, right? This 1 month is neonate, whereas rest of the month is post-neonate. Now I have a question. This 1 month, is it 30 days or 31 days? None. It is 28 days. That means 0 to 28 days is neonate period, whereas 28 to 1 year is post-neonate. That means neonate or newborn is child is considered as newborn only up to the first month, which is again divided into first 1 week and rest of the weeks. What do you call this first 1 week as? Early neonate. And then you have late neonate. Okay. Is that clear? So 0 to 7 is early neonate and 7 to 28 is late neonate. Now comes the next question. What do you mean by stillbirth? A child dying before born, but after attaining viability. So the question is, when does a child attain viability? At 28 weeks of gestation. Of course, there is a change in guideline as per WHO. Now WHO is saying that even after 20 or 22 weeks, the child may be considered as viable, but for our guideline or for this particular formula, it is 28 weeks of gestation. That means a child dying after 28 weeks of gestation, but before birth is stillbirth. Okay. Next question. What do you mean peri? Word meaning in and around, right? In and around. Peri. Okay. So what is perinatal? In and around the time of birth. So this includes few days before birth and few days after birth. Few days before birth is nothing but the time that you consider as stillbirth, and few days after birth is nothing but the time that you consider as early neonatal period. Okay. So that covers the numerator as well. So we have already seen what is the denominator. Denominator is number of live births. Okay. And there is a slight modification. In perinatal, perinatal means number of children who are dying stillbirth plus in the early neonatal period, that is a numerator. There, since stillbirth is also included in perinatal mortality rate, the denominator includes live birth plus stillbirth. Okay. Hope you're with me. Live birth plus stillbirth. So that completes our MCH indicators. Shall we stop? So thank you guys. We have covered, chapter wise. If I get time, I'll come once again and we will cover the rest of the topics as well. So we have covered more than half. Now what is left are small chapters, occupational health, then disaster management, biomedical waste management, and such things. Okay, so that if time permits, I'll come once again. Okay, so all the best for your exam. And thank you so much for listening for 3 hours. It's almost 3 hours, right? So let's meet again. Okay, bye. And if you want, I can give you my, wait, somewhere. I think it's towards the end only. I actually came with a lot of slides. If you have any doubt, you can mail me to drrajasi@yahoo.com, or you can join my PSM Telegram group. I'll be available all the time. I may not be able to give you a timely answer if I'm busy, but definitely I'll get back to you. So all the best and stay in touch. So this is something that I always say. If you have a dream, always try to pursue that dream. Because, like, who said this? Paulo Coelho said in Alchemist, when you want something, if you really, really want something, the whole universe conspires in helping you to achieve it. So if you have a dream, definitely you will reach it, because the whole world, and I also belong to that part of the world, we all will help you to achieve it. So all the best and God bless. Bye.